मैम मैम के साथ बहुत टाइम से हूँ, जब से आया मैम के साथ ही रहा मैं।
Roshni, I think we have 50 plus attendance now, and I think I'll just give a brief overview, and I think we can just start into the wonderful academic feast that we are hosting. Obviously, it's going to be a monthly event from at least the Gangaram Institute of Medical Oncology Department, and obviously, Urology Department is also contributing in the terms of second days being completely driven by Dr. Ashwin Malia, who's a fantastic uro-oncologist over here. Good evening to all, and I hope that everybody who is joining here and he or she is here to learn. And a lot of things I have heard about, in the past that most of the meetings are commercial driven, or they are not exactly focusing on the major core group of the audience, which are our students. In the upcoming series, which very soon Gangaram Hospital will take initiative along with collaboration across all over Indian societies, we are making sure that the courses or whether the discussions we are doing for students, we will give you a disclaimer that these are commercial entities and these are non-commercial conferences, so that they can select by themselves where they want to become an audience or even want to participate, and they drive the best of the best benefit out of these conferences. So without further delay, I would like to request my all speakers to be on time, my all panelists to be on time, and they have to be very crisp and clear with their answers, so that at the end of each and every session, the message should be loud and clear, and every student should be able to learn the topic which he or she is listening to. So, without delaying further, I think, Roshni, are you there?
Yes, sir, we are there.
So, are we ready to go in for the first session of today's Bonanza?
Yes, sir, it's perfectly right.
Perfect. So I thank IAIO who has given me this wonderful opportunity, and this is the first of many to come. And my wonderful technical team who will be there besides me. And I think let's start the discussion. And Roshni, I ask you to take over the discussion and take the agenda forward, and just start the wonderful academic feast we have planned for our students.
Thank you, sir. Thank you, sir. Thank you so much for the powerful impact. Now, I would like to welcome Dr. Krupashankar, sir, Director and Consultant Medical Oncologist from NSAC Cancer Cure Center from Coimbatore, to give a talk on risk-adapted neoadjuvant and adjuvant therapy for HER2 positive EBC. Sir, over to you, please.
Thank you, Roshni. I'll just share my screen and we'll get started right away. Well, are my slides visible?
Yes, sir. Visible, sir.
Right. Fine. So, a very good evening and a warm welcome to everyone. And at the outset, before I begin, I'm going to take this opportunity to congratulate IAIO for this wonderful academic initiative and also thank them for the opportunity. So, what I'm going to do over the next 15 minutes is I'm going to take you through the landscape of HER2 positive early breast cancer and locally advanced breast cancer with a focus on risk and response adapted therapy. We're looking at treatment escalation and de-escalation strategies in the current era. So that's what we're going to look at. Obviously, that's my disclaimer. I'm a medical oncologist, so this is going to definitely be a medical oncology driven talk.
As expected from Dr. Kripa, I think you have chosen the right reference over here, and obviously you will do the justice to this topic. Just a request which I'm going to do with every speaker: make sure that at the end of the slide, just tell students few pointers or takers from the discussion which you are going to cover in the next 15-20 minutes.
All right, Aditya, done. Great, mate.
Thank you.
Sure, mate. So, to begin things off, why are we looking at doing neoadjuvant systemic therapy? We always talk about downsizing, downstaging, and then getting to a pathological complete response. And the reason why we believe that it's not only prognostic, but also predictive. Meaning it's not an all or none phenomenon. We have residual cancer burden ranging from 1, 2, and 3. And depending on the depth of response, your prognosis also differs. And people who don't achieve a PAT CR, you have an option of going on to response adaptive therapy, which means you can escalate treatment based on the response. So that's where we're looking at. And also remember that another key component is you can also make patients amenable for breast conservation as well later on by doing neoadjuvant systemic therapy. So that's in a nutshell as to why you would want to look at doing neoadjuvant systemic therapy, because you're addressing the micrometastasis also earlier. So who should be considered for neoadjuvant chemotherapy? So remember, as far as HER2 positive disease and triple negative breast cancers are concerned, any lesion which is more than 2 centimeters, T2 and beyond, should definitely receive neoadjuvant therapy, be it with HER2 directed targeted therapy and then your Keynote 522 with IO plus chemotherapy as well. And so I think that's definitely the gold standard as far as doing neoadjuvant therapy is concerned. So let's get into the main crux of it, right? So is there a role for anthracyclines in the current era? And this was one trial which looked at addressing that question. Can you do away with anthracyclines? So this was TCHP up against FEC followed by TCHP. Well, I think the one key criticism about the study was that they looked at using 9 cycles of TCHP, which I don't think in practice, and most of us would not do that. We would stick to doing around 6 cycles. So that probably they ended up over-treating patients. But nevertheless, good trial design. They looked at seeing if we could avoid anthracyclines, and the primary endpoint here being pathological complete responses. And look at the primary endpoint. This was a positive trial. As you can see here, the pathological complete responses were on par, 68 versus 67%. So does that mean you don't really need anthracyclines in the current era? I think that's definitely yes. You don't need anthracyclines in the current era to get your responses. And I'll also talk about, do we need platinums as well as we move along? Because that's where we're getting to TCHP versus THP. And I'll show you the data on that as well. So that's probably the current state of anthracyclines. Is it still needed? I don't think so. And look at the EFS and overall survival, even though these were not primary endpoints, these were secondary endpoints. Nevertheless, you could see that the EFS and OS were also non-inferior at 3 years. So like I said, now that one part of the question is solved, let's look at the next question, which is, do you need a platinum as well? So this was again presented at ASCO 25, the NeoCard HP study. And this looked at the addition of carboplatin versus just THP, like I said, THP versus TCHP. So you're looking at de-escalation by avoiding platinums as well. So earlier we saw avoiding anthracyclines. Now can you do away with platinums as well? So again, this trial also had a primary endpoint of pathological complete response and secondary endpoints of EFS, DFS, and overall survival. And as you can see here across the board, meaning in the overall intention to treat population and the hormone receptor negative and triple positive subsets as well, the pathological complete responses were on par with each other. So this led to, we're still waiting for this trial to be completely published. So this is just the abstract. So we know that this is non-inferior, and we have another trial, a similar trial called HELENO-6 as well, which has shown that the pathological complete responses are similar between THP and TCHP. And I'll show you that. So this is just a one-slide summary of the HELENO-6 data, Chinese data. Again, if you want to believe in the Chinese data, nevertheless, but I think they're really coming up with really great studies, the Chinese data. So again, similar sort of trial design, similar question being asked, and similar results as well, as far as the primary endpoint of pathological complete response. So now we've seen that you could probably even do away, probably in stage 2 as well. You don't need the platinums. So that's probably my working algorithm. Stage 2, do away with the platinums. Stage 3, you could, if you want a much more of a rapid response or adaptive response, you could probably contemplate TCHP. But otherwise, THP for all said and done is probably good enough. So next, moving on to the next, how you could further on the gains that we've seen earlier. First you saw anthracyclines, then platinums, and now can you completely eliminate chemotherapy? And that's where we're going to look at probably as far as early stage HER2 disease is concerned. So this again is a lymphoma type of regimen, which is trastuzumab plus pertuzumab for 2 cycles, then response. If you had a 40% reduction in SUV, then again they were considered to be responders. Then they were given chemotherapy. They were continued along with only with trastuzumab and pertuzumab. Non-responders, they were given chemotherapy at any point in time. So that was my reaction where we headed to. Chemo-free regimen probably becoming a reality. So this again was a phase 2 data and looking at response at rapid therapy as well as PET-CT based response as well. And I'll show you this is the entire trial design. Look at it, wonderful design. They looked at adding chemotherapy at any point if they did not achieve a complete response, be it albeit a radiological response and then a pathological complete response as well. If at any point that was not attained, then the patients would go on to receive chemotherapy. Otherwise, only dual HER2 targeted therapy. And then the primary endpoint was pathological complete response in the PET responder group, which was the group B, and 3-year IDFS. So I absolutely agreed that this is not going to be applicable for all of our patients. And I'll talk about how do we go about selecting those patients who might benefit from this strategy as well as we move along. But the primary endpoint, again, pathological complete responses with only dual HER2 blockade was around 38%, which is quite interesting as far as this data was concerned. Now, if you look at the IDFS and the distant disease-free survival as well, absolutely on par, even in the group B without chemotherapy, who did not receive chemotherapy at any point. And this was around 30% of the entire population. So you're seeing that you could probably avoid chemotherapy in about 1/3 or close to 30% of the entire population with this strategy of leading in with just dual HER2 targeted therapy, and thereby cutting down on the toxicity as well. As far as the treatment emergent adverse events were concerned, as you could see here, the group B without chemotherapy, the adverse events were much lesser. So no toxic-free and chemo-free regimen as well. So like I said earlier, I told you how you would look at probably picking on these patients. So this is one way of doing it. We've all heard about the Oncotype DX. So welcome the HER2 DX as well. So this is being done by Reveal Genomics, and Zydus is already in talks to bring the test to India. So we should have this test available to us in India within the next 6 months. So it looks at 3 different parameters, tells you about the risk of relapse, your likelihood of attaining a pathological complete response, and your HER2 mRNA scores. So these are 3 parameters that this test gives you. So again, it's based on a lot of variables like your immune cell infiltration, the HER2 expression, luminal proliferation, the amount of proliferation, tumor stage. The good thing is it incorporates clinical parameters as well, like your tumor stage and nodal stage as well. So it's not just the genomic factors that are being looked at, you're incorporating the clinical plus the genomic risk. So that's probably one way which the HER2 DX stands above the Oncotype DX, which takes into account only the genomic factors. So it's no longer a question of genomic risk overriding the clinical risk. It's a question of putting together the clinical risk along with the genomic risk. So like I said earlier, clinically low risk, you could probably look at, and this is what I meant. So probably in those patients who have a low possibility with the HER2 DX score being low, the addition of HER2-directed therapy probably did not add much, as you can see from this chart. And probably the patients with the medium score on the HER2 DX, or the intermediate risk as we would call them, probably benefited more with multi-agent chemotherapy. And the high-risk group is the one that benefited the most with dual HER2 targeted therapy. So that's one way of looking at interpreting this data. So if you have, but again, criticisms about this as well, the HER2 DX is that it's been based only on retrospective validation up until now. It's been validated on a lot of trials like the APT trial, the ATTEMPT study, and so on and so forth. But nevertheless, there is no prospective validation as of yet, but it's already endorsed by the European Society and the CIOM. The Spanish guidelines already recommend this test as part of their recommendations. So again, just to summarize on the HER2 DX, it tells you the likelihood of attaining a pathological complete response, your risk of relapse, and also the mRNA HER2 expression score. So somebody with a low risk, you would probably want to look at the magnitude of benefit with HER2 targeted therapy is minimal, whereas intermediate risk, you would probably want to give multi-agent chemotherapy, and high risk, you would probably want to give them dual HER2 targeted therapy. That's one way of picking out these patients who are likely to benefit the most. All right, now let's move on and look at how do we define high risk HER2 early breast cancer. So anybody who's got any residual disease, I think that's a no-brainer. If you have had neoadjuvant therapy and you still have residual disease, then you're definitely looking at somebody who's got high risk for recurrence. And any node positive or locally advanced disease, T3, T4, automatically becomes high risk. So I know this is pretty early guidelines from 2021, but if you look at what's really changed, nothing has, because the response adaptive therapy started back then. And if patients who did not achieve a pathological complete response, TDM1 still remains the standard of care for up until 14 cycles. And if you do happen to discontinue because of toxicity, then you could look at going back to trastuzumab and completing 1 year of therapy. So this was the Catherine data, which led to the approval of TDM1 in the adjuvant setting as part of response adaptive therapy. So they took in patients with HER2 positive breast cancer who had residual disease. The randomization was between TDM1 versus trastuzumab, and the randomization happened at 12 weeks. The key thing to remember is only around 20%, close to 20%, received dual HER2 targeted therapy. The rest of the patients received only single agent or HER2 trastuzumab alone. So I think that's one key thing that I wanted to highlight on here. And then this was the primary endpoint. The 3-year IDFS early readout it met its primary endpoint of improvement in IDFS of 88 was 77%, absolute benefit close to 11%. But that again led to this, where were they failing? Where were these patients actually failing? And you could see that the CNS recurrences actually didn't seem to be much of, there was not much of an improvement as far as the CNS recurrences was concerned with TDM1. So meaning probably you're missing out on an opportunity to cure them. And that's where probably the extended data, where you're looking at extended neratinib for 1 more year came in. But that comes with its own fair share of criticism. So I'll take you through that as well quickly. So this was the readout at the update as well at 8 years. And you could see that the CNS recurrences still remained a challenge as far as even with adjuvant TDM1 was concerned. So this was the final IDFS analysis at 8 years. And you could see that the curves are actually staying widely split apart and staying that way even at 7 years. So you're getting to see the absolute benefit of close to 13% at 7 years, 80 versus 67. And across the all one disease, T1A or T1B, or less than 1 centimeter residue, the magnitude of benefit was slightly lesser, as opposed to patients who had more than 1 centimeter residue. But then again, these are only exploratory subgroup analysis. The numbers were too small for us to draw any meaningful benefits, so I wouldn't want to read too much into it. So any residual disease, TDXT remains the standard of care, but the magnitude of benefit probably lesser for patients who had less than 1 centimeter residue, as opposed to people who had more than 1 centimeter residue. Now, what about the overall survival data? It's still not yet mature, but at the second interim analysis, you could see that there was an absolute improvement of close to 5%. Nevertheless, this data is still immature, so we'll have to wait for longer data before we get the final OS analysis. Again, one criticism about the study again was that, in the setting of a curative intent, you had a close to 20% discontinuing treatment because of toxicity. Now, is that okay? So you could see that the treatment discontinuation rates were close to 18%. Agreed that these patients went on to receive trastuzumab, again, if they discontinued because of toxicity, agreed. So, again, the purest way of arguing about that would always be that, despite that, they were still able to meet the primary endpoint of showing an improvement in IDFS, despite close to 1 in 5 discontinuing because of toxicity. And remember, even if they did discontinue, they went on to receive trastuzumab. So it was not like they did not receive any HER2-directed therapy. So again, I know that's what set the standard of care, being TDM1 for anybody with invasive residual disease. So you're getting to see an improvement at the second interim overall survival analysis as well of close to 5%. But again, the data is not yet mature, and the 7-year IDFS, you're getting to see the magnitude of benefit still being preserved at 7 years. So again, moving on, I think the next, obviously, TDXT is everywhere. So could that be the next contender to the throne? You're looking at the DB05 or the Destiny Breast 05, which is looking at TDXT versus TDM1. And interestingly, we'll soon have the readouts from this study as well. Probably looking at, then probably we'll be looking at having to do TDXT right up front. That's probably my reaction as well. We're looking at all these trials being done and, pushing these molecules right up front. But nevertheless, this is all good news. And again, looking at adjuvant TDM1 plus tucatinib as well, as opposed to just TDM1. That's another interesting trial called the Compass HER2 Residual Disease or RD study, which is ongoing with the primary endpoint of IDFS as well. We're still awaiting the results on this study as well. So quickly onto the adjuvant setting. So why is 1 year considered to be the gold standard? Why not 6 months? So I think in the current era, I think, if you're going to avoid anthracyclines, 1 year definitely remains the standard of care. Well, if for any reason you want to do 6 months of trastuzumab based on the Persephone data, you will definitely have to give them anthracyclines. And this again data from TMH as well, where they've looked at and they've published the data as well. So if you want to do a shortened course, you cannot avoid anthracyclines. You will have to do them. And one way of picking out who's likely to benefit more from just 6 months, or who's likely to, 6 months alone would suffice, would be triple positive, node negative, and early breast cancer, meaning any T2 up to T2. So I think that's one way of looking at picking on this group. But remember, if you're doing 6 months, you cannot avoid anthracyclines, and if you're avoiding anthracyclines, 1 year remains the standard of care. And as the good old saying goes, but something will definitely be better than nothing, as opposed to giving no trastuzumab. Some trastuzumab would always be better, but does that hold true? So again, this was historical data, if I might put it that way, right now called the NOAA study, neoadjuvant and adjuvant trastuzumab. Now you can see here in the control arm, about 40% who did not receive any trastuzumab are alive and doing well at 7 years. And likewise, the HERA paradox, the HERA study. Again, At 11 years, 60% in the control arm who had not received any trastuzumab are also alive and doing well. So I think that's where this key concept comes in. You're talking about patients who are getting cured only with surgery, and then you're talking about adding to that with your addition of trastuzumab and HER2-directed therapies. But is HER2 the perfect biomarker? And the answer is absolutely no. Just like we talk about PD-L1 not being the perfect
Sorry to
biomarker.
interrupt, sir.
Yeah.
Time has up. Kindly request you to wind up.
Just a minute. I'll probably just take 1 minute. So the mechanisms of resistance quickly are that alternate signaling pathways getting amplified, like your P10, PI3K, KTM12 pathway, and then cyclin E overexpression. These are all been postulated, and then the truncated P95 protein expression as well. So again, quickly, just the last word on pertuzumab. So if you have a PAT-CR, if you're given dual HER2 targeted therapy, achieve a PAT-CR, should you continue pertuzumab? So it's not just as simple as going to bed with your favorite NCCN guidelines, even though it says you could give them for at least for node positive disease. So I'll just quickly show you that data. I think cost definitely is an important constraint in today's world, and especially in India, with a low middle income country like India. Affinity looked at answering the question of adjuvant pertuzumab as well, and you can clearly see that in the node positive subset is where the benefit is driven by. So node negative, absolutely no role for adding pertuzumab. If you have a pathological complete response, patient can afford the drug, go ahead and continue it. You don't have to necessarily discontinue it, but otherwise only in the node positive subset should you be looking at using pertuzumab. So again, that was the update on that. And then again, could you do just TDM1 plus pertuzumab alone? Unfortunately, a negative trial did not meet its primary endpoint. That was the Caitlin, and then you had the attempt study similar to study looking at TDM1 again. Phase 2 data did not meet its primary endpoint. Is there a role for neratinib in the current era, especially for triple positive subsets? Absolutely not, because that's a misnomer, right? One end of the spectrum you're talking about 6 months of trastuzumab, the other end you're talking about trying to extend the duration of HER2-directed therapy. So I think not really, doesn't hold water here. So I think neratinib out of the question as well. So I'm going to conclude and leave you with this slide. So that's the proposed strategy. You don't need anthracyclines, and now probably you can avoid platinums as well if it's stage 2 disease. And if anybody's got residual disease, TDM1 is the standard of care. So I think I'm going to quickly summarize with that and leave you with that. So less than 3 centimeters, we know the APT study, the adjuvant paclitaxel and trastuzumab, 12 weeks of pacli with trastuzumab for 1 year, is even though albeit it's phase 2 data, nevertheless is practice changing and considered to be the standard of care. And neoadjuvant chemotherapy for more than 2 centimeters on a positive is the current standard of care. Adjuvant therapy, affinity, pertuzumab only for node positive disease, and Catherine, is probably become the gold standard right now. You will have the DB05 taking on TDM1, TDXT versus TDM1 in the adjuvant setting pretty soon. Extended neratinib, not a game changer for me. And so with that, I'm going to conclude and say thank you all for your patient listening and hand it over back to the organizers. I'll be happy to take any questions if there are any. Else, I will.
Yes, sir, there is a question in the chat box. How strong is neratinib evidence?
Yeah, so like I said, I was just talking about that. I said I'm not hugely taken by that data, nor would I recommend doing that in practice. So, albeit even though it's in the triple positive subset, that has shown some benefit in as far as reducing the CNS recurrences as well. Because, that's where we saw TDM1 also failing in the adjuvant setting, as far as the CNS recurrences were concerned. But nevertheless, no, I mean, not a game changer for me. I wouldn't want to be looking at doing that in practice. Adjuvant neratinib for me, a big no.
Thank you, sir. Thank you so much for your informative session and for your time. Now, I would like to welcome our next speaker of the day, Dr. Rashmi Bansal, ma'am.
Discoveries and therapeutic models, the fight against cancer demands an integrated approach among organizations.
Consultant Department of Medical Oncology at Rajiv Gandhi Cancer
IAIO,
Hospital
world's
and Research
fastest
Center.
growing
Ma'am,
integrated
over to
oncology
you.
network.
Hello everyone. Am I audible?
Yes, ma'am. You are audible, ma'am.
Can I share my screen?
Yes, please, ma'am.
Just one second.
shall we share from our end, ma'am?
No, no, just 1 minute.
Dr. Rashmi, welcome.
Yes.
And make sure कि जो हमारे साथ students joined हैं at the end of your lecture, they learn something in their theoretical or in their practical sense, because it's very essential for them to
Okay.
start deriving the relevant information of the discussion that you are going to do.
Okay, my screen is visible.
Yes, but your slides are not. Now they are.
Now there?
Yes.
Yes, okay. So, yes. So, already Dr. Kripashankar has set the stage. He has already discussed about Catherine trial and Affinity trial and TD, XD also, Destiny Breast 05 trial. So, let me discuss it further. So, I'm going to discuss management of residual HER2 new positive early breast cancer here. So, anti-HER2 agents trastuzumab did very well as an adjuvant therapy. So, if we see the data, adjuvant trastuzumab improves DFS and OFS for patients with HER2 positive early breast cancer. So, if we see the clinical trials on trastuzumab as adjuvant therapy, so we know about HERA. So, without trastuzumab, 1 year of trastuzumab and 2 years of trastuzumab. There was no benefit with 2 years of trastuzumab. With 1 year of trastuzumab, there was DFS and OS benefit, if we see. But still there is a risk of recurrence. So we need to minimize this risk in HER2 positive early breast cancer. So what is high risk? High risk is patients with HER2 positive early breast cancer disease who have a risk of 10% recurrence. So after appropriate neoadjuvant chemotherapy and anti-HER2 therapy, any residual disease which is not achieving PCR, or after surgery first, any node positive disease, T3 or T4 disease with any node positive. So how can we personalize our approach to reduce the recurrence rates? So neoadjuvant therapy, it is a move forward towards personalization. So what it does, if after neoadjuvant therapy patient is achieving PCR, so the patients who are achieving PCR, they generally do much better than patients who have residual disease. So it can guide us to treat further. So achievement of PCR matters. If we see there are multiple trials to correlate the PCR data with the DFS. So if we see the patients who are achieving the PCR, they're doing much better than patients who are not achieving PCR. So there is a need of response adjuvant therapy in HER2 positive disease, particularly for residual disease group. So HER2 positive breast cancer patients with residual disease have poor outcomes if we see association of PCR with better PFS. So if we see the data, the patients who are having PCR, they're having better EFS, and association of PCR with improved OS is also there. The hazard ratio is 0.13. So what we can do further? So building on trastuzumab, additional anti-HER2 therapy. So the 3 therapies which are approved, there are other therapies also which are not approved. Already Dr. Kripashankar has talked about that. So TDM1 is there, trastuzumab pertuzumab combination is there, and then neratinib is there. So TDM was approved in May 3, 2019, and pertuzumab was approved along with trastuzumab in 2017, and neratinib was approved in 2017. TDM was approved in the setting of adjuvant therapy, patients with residual disease, HER2 positive early breast cancer after neoadjuvant therapy, trastuzumab based treatment. Pertuzumab was approved as neoadjuvant treatment also, and adjuvant treatment in high risk patients. And neratinib has approved in adjuvant treatment with extended treatment after trastuzumab. So there are 3 therapies available as of now: neratinib, pertuzumab, and TDM1. Neratinib, high cost, there is no generic drug available. Pertuzumab, we are using it, and TDM1 also we are using it. So now come to Catherine trial. So TDM1. So this is the trial design. So prior neoadjuvant therapy consisting of minimum 6 cycles of chemotherapy with trastuzumab. Irrespective of any HER2 therapy, it was allowed, like pertuzumab was also allowed. Residual invasive tumor in breast or axillary nodes, randomization within 12 weeks of surgery. So TDM versus trastuzumab was given. Primary endpoint was invasive disease-free survival. So now we have long-term data, 8.4 years of follow-up. So it was published in January 2025. So if we see, so invasive disease-free survival benefit, 3 years mein it was 8%, but at 7 years, these graph, if you see, at 7 years, the benefit is 13.7%. So now updated OS data is also there. At 7 years, the absolute OS benefit is 4.7%. So definitely it is doing better. If we see subgroup analysis, so benefit was there across all the groups. If we see the all clinical stage at presentation, hormone receptor positive, negative or positive, and preoperative HER2-directed therapy, any trastuzumab or additional HER2-directed therapy, the benefit was there. So it has shown promising results even in patients with small residual tumors. If we see this data, so any primary tumor stage, T0, T1A, T1B, and in situ tumors also, if we see the T4 stage, 33 versus 70%. But if we see the early stages also, it is 74 versus 82%. And the second thing is residual disease, less than 1 centimeter with negative axillary nodes. So negative axillary nodes and residual less than 1 centimeter also had benefit. So now we can, this is a guiding point for our treatment decision making. New diagnose high risk HER2 positive early breast cancer. If neoadjuvant therapy is given for 4 to 6 cycles, the patient is going for surgery. We assess for residual disease. If there is PCR, we can continue trastuzumab, pertuzumab, trastuzumab for 1 year. If not positive disease, pertuzumab we can add. If there is no PCR, residual disease is there, we should add TDM1. But this trial has certain limitations and remaining questions. So if we go back to this data, so if we see whites are 1,000 patients. The remaining patients are very less. So we don't know in our Indian settings it is going to do well or not. So there is no Indian data as of now. So key subgroups remained at risk for recurrence despite TDM1 treatment include patients who had initially presented with inoperable disease, those with node positive axillary nodes after neoadjuvant therapy. If we go back to this data, so it is showing residual disease less than 1 centimeter with negative axillary nodes. If positive axillary nodes are there after neoadjuvant therapy, how this drug is going to do, we don't know as of now. And those with both ISC2 plus and gene amplification FISH positive, how they're going to do, we don't know, because the number of patients here taken are very less. One more thing which Dr. Kripashankar already mentioned. So definitely the invasive disease-free survival benefit was there, but for the patient who had brain metastasis recurrence, the benefit was less. And one more thing, the dropouts were more, the adverse events were more than trastuzumab. So there is definitely a need of additional or alternative therapies to improve outcome in these patients. Now I'm coming to Affinity trial, which is a phase 3 adjuvant therapy trial, which is investigating the benefit of pertuzumab when added to trastuzumab plus chemotherapy. So this was the trial design after surgery for patients with HER2 positive early breast cancer, no prior invasive breast cancer or anti-cancer treatment, node positive or any tumor size, or node negative disease with tumor size more than 1 centimeter, or if node negative disease, tumor size if 0.1 to 1 centimeter, grade 3, hormone negative, age less than 35 years, means high risk disease. So they were stratified into, randomized into pertuzumab plus trastuzumab versus placebo. Primary endpoint, invasive disease-free survival. At long-term follow-up, if we see, only node positive disease had benefit of this 4.9%. In other N0 disease or hormone positive disease, there was no benefit. In fact, in N0 disease, it was minus 1%. So I don't think there is a benefit of adding this drug in any N0 disease. So what we can do, this is the proposed guidelines. So if we are going for neoadjuvant therapy, so patient is going for surgery. If PCR is there, we can continue the trastuzumab for 1 year, and if node positive disease, we can add pertuzumab. If residual disease is there, we should go for TDM1 as of now. If patient is going for primary surgery, there is no neoadjuvant treatment as given, and PT1 N0 disease is there, we should go for adjuvant paclitaxel or taxanes with 1 year of trastuzumab. If node positive disease is there, so we should give adjuvant polychemotherapy and dual blockade. Had this node positive disease, there is a role of pertuzumab. Neratinib, there is a drug neratinib. on the basis of Exinet trial, but I don't think the data is strong to give this drug. Summary: for patients with HER2 positive breast cancer, the availability of HER2 targeted agents have markedly and rapidly improved overall outcomes. There is need to offer neoadjuvant treatment for most of the eligible HER2 positive patients to adopt a response based treatment modifications. For adjuvant therapy, Catherine trial is there, TDM1 as adjuvant therapy for patients with residual invasive disease after neoadjuvant taxane and trastuzumab based treatment. We are more confident with newer data. Affinity trial, pertuzumab we can give go for node positive disease. There are few ongoing trials like for TDXD, there is a trial Destiny Breast 05, and then there is a trial pertuzumab plus TDM trial, which is not a positive trial. So okay, tucatinib trial is there, but still we don't have any approval for these drugs, so I'm not covering those drugs here. Thank you so much.
So, Dr. Rashmi, if you and I would have been in student times, what all should we remember while we are answering in the Viva or, let's say writing a theory question? What are
Yes.
the few important pointers that we need to remember? And you have also cleared your examination. So, what's your take on that?
Yes, we need to make a summary of this, like a small table, like first the stage of disease. If patient is either going for neoadjuvant therapy or not. If patient is not going for if patient is going for neoadjuvant therapy, so we should give chemotherapy plus trastuzumab plus pertuzumab. If after that, after surgery, if PCR is there, then there is no need of any other drug, only trastuzumab is enough. If node positive disease, we can add pertuzumab. But if there is no PCR, if residual disease is there, we should go. If we should offer TDM1 to the patient, then in India the finances are like constraints are there, so we should give option of TDM1. If patient wants, then we
So
should
I
go
think
for
while
TDM1.
writing a question, nobody needs to state the finances. They just
Yes,
need to be careful to, tell exactly what they should do. And
yes,
nobody, I think, will challenge them if finances or something like that discussion happens. So I think for all
yes,
the students, wherever they are answering the question in any of the major examinations, I think you should never worry about the finances. You should tell the best of the best evidence that we have.
yes. So based on our trial, we should TDM1 should be offered to patients who don't have PCR. And
Absolutely.
yesterday we should give TDM1. There new trials are there. Still, the data is not strong. We don't have any approval. So
Yeah,
as
soon
of
I
now,
think
TDM1.
TDXD will also challenge this forte
Yes,
of TDM1 and it will maybe
yes. But
go out of the
as of now, yes,
one. Yeah,
yes,
perfect. So
yes.
thank you so much. And Roshni, take over.
Thank you, sir. Thank you, ma'am. Thank you so much for your informative session. Now, I would like to call upon our next speaker, Dr. Professor Chintamani, on a topic of who can avoid afferent genital node and axillary surgery in node negative and node positive presentations. Sir, over to you, please.
Thank you, Roshni. Can I share my screen, please?
Yes, sir, please.
My screen visible?
Yes, sir, your screen is visible.
Thank you. Right. I'm audible clearly.
Yes, sir, you're clearly audible. Thank you, sir.
Thank you so much. First of all, thank you very much, Dr. Aditya and team, for this lovely opportunity to be talking about a very interesting topic. And I'm sure you freshen your minds with the St. Gallen's consensus. This was argued at length there. And when we talk about sentinel node and axillary node dissection, axillary dissection, we heard the previous two talks, and they were talking in terms of node positive, node negative disease. So you won't get out of this syndrome of positivity or negativity. And for that, you need to ask somebody to take out those nodes from the axilla to be very sure that they are positive or negative. So as of now, we are not too sure. We have an answer, and I'm sure that's why it's worth discussing. So lovely topic and a wonderful conference. Congratulations to you. Now,
Thank you, sir. All your blessing. And obviously, I will be also requesting you the same thing because you have taught so many students over the years and, in fact, decades. So just at the end of your slide deck, just give few pointers to our students so that they don't make any mistake even while writing the answer or speaking when they are asked in the viva.
Sure, Aditya, that we would take care of. And the biggest lie of the world, I have read and agreed to the terms and conditions. So please be careful as you go through the trials. Look at the finer prints, look at the minor issues which don't get covered easily. And especially as Dr. Aditya mentioned about students, it's very common for people to get loaded with trials, and confusion is easily overpowered by the pressures that you live, the world that you live in. So do understand that trials, when we mention, including especially the trials in the field of axilla, it's probably the most studied part of surgical fields in the last decade. Now, why are we discussing it? Well, we know if you could avoid axillary dissection, then you could probably avoid this. But it's not true. It's not about one adds to one and becomes two. There are many things that have got to do with lymphedema. It's not just axillary dissection. It's got to do with where do you make your incision, how do you cut through your tissues, whether you leave the arm lymphatics, whether you are doing some technical innovations to make sure that you don't damage the arm lymphatics. There's so much in it that you need to be knowing more about it. It's not just axillary dissection, then super added radiation, and in addition to that, the patient's own habitus. So there are many factors that contribute, but certainly one important factor is axillary dissection. So if it can be avoided, it's definitely on. Well, 23 and 24 were actually truly called the axilla years. And you have some wonderful trials that happen, all very robust, but with their finer prints, which you need to look at carefully. And the one that you would very much enjoy reading is this one, The Bell Tolls for Thee. This is a beautifully written article where it was described that axillary dissection may be extinct or may be obsolete in future. We haven't yet gone there. And at the same time, sentinel node biopsy, this beautiful write-up by Monica Moreau. We are not yet sure, but definitely I'll talk to you in the next 10-15 minutes about what is it that has come to support what we wanting that we can avoid axillary dissection and what are the loose ends that we need to tie. Now the paradigm shift, and I mentioned even before I started talking about my topic, axillary status and T size historically has been the most important prognostic factor or factors guiding our decision about systemic and radiotherapy. And you heard exactly the same in the previous two talks. But today, we are looking at tumor biology more than anatomy. In the field of oncology, biology is king. And anatomy and the other things are queen and the princesses. Now, if you want to look at axilla as a standalone problem, it would come as a baggage along with what you do to the primary. So many things are related to each other, and you need to be looking at them carefully. Most studied and the design of the trials has been excellent, and we've heard so much about these trials, and we are not going to be missing out on any today, hopefully. But in 15 minutes, you can't discuss all of them. But in general, the take homes from each one would be of great importance to all of us. Everybody knows about Z11, and that opened up the floodgates, and the decade opened up for de-escalation trials for axillary surgery in early breast cancer. And with the ASCO presentation of 2010 showing a good outcome, most trials shifted towards where you can avoid sentinel node biopsy. And that's how the funding happened, and that's how the research happened. And they were very keen on taking that as an experimental arm. And I think we are getting there, although we are not there. Now, that's a long laundry list of the trials where we talked of no axillary surgery, even if you find sentinel node is positive. We are basing everything on Z11, and we know there were problems with Z11. If there is time, we can discuss that. And there were problems with the Amaros, where you substituted surgery by radiation. I don't know how does that make a difference. If you're addressing the axilla, you're addressing it. And if you're bombing, you're killing the terrorists, or you're carpet bombing, it doesn't really make a difference when it comes to the outcome. So read it very, very carefully. But importantly, in Cenomec, they looked into details with the macro and micrometastasis, and also mastectomy, which was not included in the Z11. And as a surgeon, I can tell you very, very clearly that when we are doing the dissection in the axilla, all this is related to how well you do your sentinel node biopsy, how many nodes you take out, how well you ensure that you don't damage the draining lymphatics, how well you make sure that you target them adequately. So there is a robust body of evidence that in some very good cases that are very selective, very selected, and definitely where you explained it to the patient adequately, the decision is always shared decision making. You can maybe in some cases spare the axillary dissection even if it is sentinel node positive. If it is sentinel node negative, then there is obviously no problem. Now, when you look at the Cenomec, which I just mentioned, you can see that the difference between the ALND arm and the sentinel node biopsy arm was not huge. But many a times, statistically, you could be going places like Mark Twain said, there lies, there damn lies, and there are statistics. You get all the data, you facts together, and you can twist it to suit your requirement. Many patients in Z11 got adjuvant radiation as a tangential radiation to the breast. They got it in the axilla. Many of them actually got chemotherapy, which was not accounted for. And we are taking that as a basis. It can be a bit of a challenge, and you should look at it very carefully. So the de-escalation of the axillary surgery in breast cancer started way back in 1970. And I still go back each time when I have to talk about it to NSABP4 trial, which made us realize that you don't need to have as many nodes. You need to make sure that your endpoints are met. So that was for how and where you do axillary lymph node dissection. Then, of course, B32 came with sentinel node biopsy, where you could actually avoid axillary dissection in many negative cases by doing this study and making sure that you don't mix up. And no LND for node positive, I've already mentioned Z11 and the other trials. And then came even post NACT in not really locally advanced breast cancer, the larger tumors, which were initially node positive, if they become node negative, you can do sentinel node biopsy and treat them like you would treat the primary. Like the idea was if the primary is responding, so is the axilla. That was the MD Anderson data, which made all the difference. And we started looking at lymph nodes like we look at the primary. And now omission has come in the form of sound trial and INSEMA. Both these trials they're very large, good exclusion criteria. They were very careful with their ultrasounds, and they both got almost the similar results, which are very gratifying when it comes to omitting sentinel node biopsy in node negative T1 luminal postmenopausal BCT patients, not all. Please read these prints very, very carefully. NCCN guidelines don't include or incorporate sound trial or INSEMA because ultrasound, for all you know, doesn't matter who does it. It's very operator dependent and you can't swear by it all the time. So it doesn't have it starts with the sentinel node biopsy in node negative patients. So how do you find sanity in this axillary chaos? Now, we have all been finding that it is no longer part of the surgical intent to clear off the axilla till the last cell comes out. It's about staging the axilla now. So it's a staging procedure which can be made less morbid by doing sentinel node biopsy. And in many favorable cases, you can avoid it. But we don't have enough data to have the same thing applied to invasive lobular carcinoma or luminal grade 3 T2 tumors, premenopausal patients, those with mastectomy, TNBC, HER2 positive upfront surgery candidates. And as of now, we need to be working hard at getting the sound trial and INSEMA into our guidelines. And in future, we are looking at genomics and AI support for making those decisions. So we don't necessarily need the node positivity to take the calls that you heard in the previous talk. So all three are basically diagnostic and staging tests. Of these, first two are more reliable and accurate than the other one, but they're invasive, morbid, and costly. So the trouble is you don't yet have a standardized ultrasound way of looking at it. So there were a few trials that were done. They were basically cohort studies, 4 of them, and they found a negative predictive value of ultrasound to infer the tumor burden was less than 2 positive nodes. And it was actually reasonable. If you look at it from the point of view of 95%, that means it is possible to rely on ultrasound. So in theory, friends, there's no difference between theory and practice, but in practice there is. And there are issues. You need to take this concern into the multidisciplinary team meetings and decision taking. And more importantly, You should not allow the de-escalation of other modalities for while you're de-escalating the axillary treatment with one modality, that is surgery. So same time, you need to standardize the information when you're going to make a shared decision with the patient, because you need to inform them that I've left something behind. Very rarely do patients accept it, and in the real practice, you find it extremely difficult. And you need a very reliable, a regular, reliable means regular and reproducible ultrasonologist who does only breast all the time. So this is the summary of all that I wanted to say with the talk. If there's a node negative patient, clinically and radiologically negative axilla, there's nothing like clinical axilla anymore anyway. After AJCC 8th edition, you need ultrasound. Older patients with early breast cancer, those that are 70 years old and beyond, ER positive, HER2 negative, small T1 invasive, the beautiful cancers that don't kill anyway. If you leave them alone, maybe if you just sing a song, they'll do well. Guideline-based recommendations are sentinel node biopsy can be omitted, especially if the patient can receive hormone therapy regardless of node status. You have CalGB, choosing wisely the ASCO thing, and the choosing wisely has spread in Europe, and it was discussed at length. DCIS doesn't require sentinel node biopsy anyway, unless you're going to do mastectomy, because you won't have breast next time to assess the nodes. So mostly there are no nodes involved in DCIS except microinvasion, or there's minor invasion, which I call as missed invasion. So you may do sentinel node biopsy in select cases, but it's not recommended as a routine. But if you're doing mastectomy, it is recommended. But in some very good cases, you may avoid it. Post NSCT, you can downstage the good cancers, but you need to clip them before, and you need to have at least 3 nodes or more than those nodes in sentinel node biopsy. And you must try to get, of course, you have Z1071, which also includes some of our data, our own publication, Sentina trial, and you have the SNF-NAC trials. But you need to do at least the dual method, and try to do the targeted axillary dissection, which we are validating our own, where the clipped nodes would be, this is the sentinel node biopsy post NSCT. This is the part which is included in the Z1071. And this is the targeted axillary dissection. This is one of the recent cases that we did at Gangaram. And you can see the clip and the blue node are in the same place. And then you can do the resection of this node and maybe some tissue around it, what is called as a targeted axillary dissection. And patients with limited sentinel node involvement, that is 1 to 3 positive nodes, the typical Z11 kind of patients, the ones that you don't get to see very often in this part of the world, so don't replicate it blindly. If you cannot do it, don't say it's not required. So you need to know the procedure to be able to not do it also. Z11 had T1, T2 tumors, 1 to 2 positive sentinel nodes, not matted or bulky. Who decides that? It's very subjective. Planned whole-based irradiation and no neoadjuvant therapy. That's a summary table of all these types that I actually discussed. And at the end, I'll leave some time for discussion. There is nothing more deceptive than an obvious fact. So be careful when you're interpreting the data. As of now, we need to look at Indian solutions to Indian problems. If you find a patient who agrees with what you got, you will need to make a shared decision. But yes, we are moving towards doing less and less axilla and axillary dissection. Thank you very much.
Thank you so much, sir. I think it's one of the most important questions that is being asked from medical oncologists, and obviously we are not the expert in that. So I brought down India's favorite expert on the biopsy of sentinel nodes. So tell me, sir, which is a center where we can say that this is the right center to do a sentinel node biopsy with the right setup? What all is essential, and how many SLNDs they should have already done before tagging them and making us confident, okay, if this SLND procedure is being done in this center, then we are okay to go ahead.
Brilliant question, and the answer is simple. One is Gangaram, of course, and my previous institution, Safdarjung, where we validated it. But you asked the second part of your question is very good, which is unless you validate with at least 30 cases where you have also done axillary dissection to find out the false negative rates, which should be less than 7% to 8%. Ideally, it should be less than 5%. It is not recommended. So how do you validate it? You'll have to do sentinel node biopsy, and you'll have to complete the axilla and find out how right or wrong you were. Preferably, you can use the dual method with the tracer, and you have a shorter half-life isotope or a longer half-life. Or we are using now ICG at Gangaram, and we got that camera, so you can actually see it all light up. I showed that picture. This is a recent one only. But post NSCT, which was the second question, we are still validating. We have done those 30 cases in the other institution, and we are sent it for publication. After that, we'll be doing targeted exudative dissection in most cases.
So again, for medical oncologist, if I am asked a question that how sentinel lymph node dissection is done, because examiners love to ask us out of the box question, because for me it's an out of the box. So can you just in few pointers explain 1, 2, 3, 4, 5 steps of doing an SLND and what all is required and essential while doing an SLND?
Perfect. So, first of all, understand when you talk about a sentinel lymph node, it is supposed to be the first node that gets the cancer or the drainage. It may not always be cancer, it's the lymph that reaches. And usually, this lymph node is located somewhere close to the chest wall between the lateral thoracic vessels and the pedicle that most surgeons know. Your answer would be first of all, you'll brief the patient about it. If sentinel node is sent, I'll take out 3 to 4 nodes, and if it comes out to be positive, you should have spoken earlier with the patient that I'm going to do exudative dissection or I'm going to do exudative conservation. Presently, we are all doing exudative dissection for node positive disease, except in very elderly and where we have other reasons. Second, now you inject the dye, which is usually methylene blue in this part of the world, where I had brought it isosulfan blue long back when I came back from England. We can't get it here, it's expensive, and we found methylene blue is very useful. And I showed you that study where we validated methylene blue, which is cheap and easily available. It's available in every institution. We inject about 2 to 3 ml around in the periareolar space, and then we give a gentle massage for 5 to 10 minutes, which may not be required. And that would be enough for us to make a small incision along the axillary crease where the hairline is in the axilla. Make a small incision, we dissect until we find the blue and hot node. I forgot to mention about the isotope. I kept it separate. Isotope injection, you need to collaborate with your nuclear medicine colleagues. There are 2 ways of doing it. They put an injection a night before, which is very comfortable for them. But naturally, you need a longer half-life isotope, which is more easily available rather than the shorter one. So shorter one can be given in the morning. So what we observed in most of the countries is given in the morning, and then you look at the blue and the hot node. You dissect it out, it goes for frozen section. The pathologist checks it by frozen section, not by immunohistochemistry. It's only H&E. Please remember that. That will be asked in the exam. There are some trials where they've used doing IHC and they realize there are micrometastasis and isolated tumor cells. So they don't change your sentinel node status. That's why, because H&E is done. And if positive node comes, they report in 15 to 20 minutes. Our people are smarter. They get back in 10 minutes, maybe 15 minutes. So we are able to then take a call. That's in nutshell. Otherwise, for all those who are interested, you can visit my YouTube channel. There is a practical demonstration of how we do it. And it's not a bad idea, as Dr. Aditya mentioned. Like, we would like to listen to all brilliant talks that the medical oncologists delivered just before. You should know what exactly happens in the operation theater.
Yeah, and one question there is in the chat box that if you have a clinically node negative HER2 new positive breast cancer patient, which is post NSCT, and if initial clipping or SLNB not done, and on report post surgery you turn out to have YP clinically, okay, no, not the surgery, it is clinically YCT 0 and 0. So should we do ALND? Well, I don't think you're required to do an ALND.
I'll do a sentinel node biopsy, and it is perfectly on now, but I'll take out a little more numbers. I'm telling you what I'll do since that's direct. 4 to 5 nodes, I'll be happy. And 3 to 4 nodes, I'll be happy, and I'll wait for the report. If it comes out to be positive, then I'll try to do exudative dissection up to level 2. Most of us would do that because we have not clipped the node. So we would not know which node was initially positive and which one is negative or positive now. So that is the reason. Even if I use blue dye, I do a sentinel node biopsy, I'm not 100% sure. Very careful.
But the best of the best patient is to make sure that if you are going for an implant surgery, and that's the right time to go for sentinel lymph node. And obviously, if you do it post the new adjuvant, obviously your results will not be as good as
Yeah,
patients
Aditya,
who have gone NC.
you're right about this. It was debated ad nauseum. And now the pre-NSCT sentinel node biopsy concept is gone. It is post-NSCT now, like the Sentinel trial showed it, and Z1071. Now the FNRs are less than 10%, and less than 10% is not bad, 7 to 8%, as compared to the exudative dissection that you would do. But whenever in doubt, take it out.
So again, thank you, sir, and thank you so
One more
much. And now we move on to the next.
Can I take this question? There is sentinel node biopsy required before putting triple negative patient with N0 on NSCT or label it just radio? Yeah, that has been answered. So thank you. Sorry. I think that has been answered. So we would not do it before. The two surgeries the patient would be subjected to. And if I may take only 15 seconds, Aditya, I just need to tell them why did this Z11 all these trials actually come into practice? Because there were not enough pathologists to do frozen in the West. So they would send the sentinel node biopsy, close the patient will go home. Then the report would come with histopathology. So it was like taking the patient second time for surgery. That is why they started studying whether they need second surgery or not. We are doing frozen. So from frozen is positive or negative, we can take a call much more easily. But there's nothing like pre-NSCT, post-NSCT SNB now. We do once, and that is post-NSCT. Like we treat the primary after NSCT, we take the footprints are not counted, unlike in the head and neck. So same thing in the axilla. Thank you, Aditya. It was a pleasure.
So much, sir. Thank you so much, and always been, it has been a pleasure for us to have you here at Gangaram with us. And yeah, thank you so much. So Roshni, next, you are okay to invite the next speaker.
Thank you, sir. Thank you, sir. Our next speaker is Dr. Sunil Pashricha, Senior Consultant in Oncopathology at Rajiv Gandhi Cancer Institute and Research Center, who will address HER2 low and ultra low in breast cancer. Sir, over to you, please.
Am I audible?
Yes, sir.
Okay, so good evening, everyone, and it's really a pleasure to be here at this platform. And at the outset, I would like to thank the organizer, Dr. Aditya Sarin and Dr. Ashwin for giving me this opportunity. So I can share my slides.
Yes, sir.
So my slides are visible?
Yes, sir, it's visible, sir.
So I'm putting it on the full screen.
Yes,
okay.
Sir.
So I'll be talking about the HER2 low and ultra low in the breast cancer. So we all know that HER2 is a transmembrane glycoprotein with the intrinsic tyrosine kinase activity encoded by the ERB2 gene, which is located on chromosome 17. And we know that HER2 amplification or the overexpression there promotes the receptor hormone heterodimerization, which actually causes the constitutive activation of the several downstream pathways that ultimately leads to tumorigenesis. So what is the significance of HER2 testing? So benefits of HER2 targeted therapy has actually revolutionized the treatment landscape in many solid tumors, and the highest magnitude of impact has been seen in the breast cancer. It can be considered as a game changer or a shifting of the goalpost. So HER2 biomarker scoring criteria and the final result is different across the various tumors. Accurate evaluation of HER2 status is very critical to select the right patient who can derive the benefit from the life-saving HER2 targeted therapies. So in the breast cancer, we know that it's a heterogeneous disease. It's not a single disease, and whenever a new case is diagnosed, it is subjected to the biomarker testing, for which HER2 is a very integral part. And on the basis of the result of the HER2, and the molecular subtype assigned is when the HER2 is positive, it is the luminal B or the HER2 positive, and on the basis of molecular subtyping and clubbed with the staging, that forms the decision for the subsequent treatment. So the HER2 testing has actually evolved to improve the identification of the HER2 positive breast cancer patients, and ESCOCAP guidelines, they provide the algorithm to interpret the HER2 results, not only on the IC and also on the in situ hybridization assays. And the SCOCAP guidelines, they periodically evaluate the emerging clinical evidence and evolving diagnostic needs to update and improve the standardization of HER2 testing and consistency of the results in the invasive breast cancer. So the first guidelines, they were released in 2007 by the SCOCAP, and they were based on the premise so that to select the right patient who can receive the treatment for HER2 targeted therapies. These guidelines, they were subsequently revised. They underwent a major revision in 2013, and then again also there was again the revision. There was a focused update in the 2018, and whatever we are following recently, they were all based on the 2018 guidelines. So what are these guidelines says? So for a HER2 3 plus, which is we call it as a HER2 positive, there has to be a circumferential membranous staining which is complete in more than 10% of the tumor cells. For HER2 2 plus, you have to have a complete staining which is weak to moderate in more than 10% of the tumor cells. And for 1 plus, which is considered as negative, there is an incomplete membranous staining that is faint or barely perceptible in more than 10% of the tumor cells. And for IC negative, that is score 0, either there is no staining at all, or there is a membranous staining that is incomplete or faint, barely perceptible in less than 10% of the tumor cells. So in 2023, we had a guideline update. So there was nothing new in this guidelines update. The reporting algorithm remains the mirror image of the 2018 guidelines. So it affirms the prior 2018 reporting recommendation. However, the guidelines emphasize to do a due diligence in distinguishing the HER2 negative score 0 from HER2 negative score 1 plus. And why this was important? Because in the Destiny Breast 04 trials, the trastuzumab deruxtecan has shown to be effective in the patients with the low HER2 expression, which are actually defined as HER2 1 plus or HER2 2 plus, which subsequently FISH negative for amplification. The same thing was reinstated by the NCCN guidelines that the distinction between 0 and 1 plus is currently clinically relevant in the metastatic setting, since the patient with HER2 1 plus or 2 plus FISH negative, their results these patients may be eligible for the treatment targeting non-amplified levels of HER2 expression. And also the HER2 0, the HER2 IC0 and low HER2 expressing breast cancer, they have a different clinical feature. This was a large study by Shinetti et al. And they have found that in comparison to HER2 score 0, the breast cancers expressing low levels of HER2 are more frequently, they are hormone receptor positive and luminal. They have a larger primary tumors and they are associated with a more nodal involvement. So you can see this pie diagram, then you can see that on the right side is the low HER2 expression. So you can see the association with the triple negative breast cancer is only 12%, whereas the HER2 IC0, the association with the TNBCs are 30%. So HER2 IC0, they are more commonly associated with the TNBCs as compared to low HER2 expression, which was statistically highly significant. So in this year, in the second quarter of this year, we have we have a recommendations from the 3 international agencies and from the NCCN, from the CAP, that is the College of American Pathologists, and the ESMO Oncology. So they have actually, there has been a change in the guidelines. So what they have done is that in the reporting algorithm, they have dissected the score 0 into 2 important subgroups. That is, one is the score 0 HER2 null when there is no staining. So there is no absolute no staining, it is bereft of any staining. And the other category in the score 0 is the score 0 plus, which we call it as a HER2 ultra low. So here the membrane staining is there, but which is incomplete, faint or barely perceptible, but that is less than 10% of the tumor cells. So this was the change. And why it was important? Because in the Destiny Breast 06 trials, they have found that it was not only the HER2 low, even HER2 ultra low, which is the 0 plus. So the metastatic breast cancer who had received more than one or more lines of endocrine-based therapy, the treatment with trastuzumab deruxtecan, that resulted in a longer PFS than chemotherapy. So FDA has approved the FEM trastuzumab deruxtecan for HER2 low and also for HER2 ultra low as determined by the FDA approved tests. Now, this is very important when I talk about the FDA approved tests. So these are the companion diagnostic tests. So whether you are using a drug as a trastuzumab for HER2 positive tumors or even for the lower ultra low, the FDA approved assay should always be used. So for the utilization of the trastuzumab for HER2 positive tumors. So there are 4 FDA approved assays. One is the Bond Oracle by Leica, Hercept by Deco, then this Insight HER2 by Biogenix, and Pathway from Roche Diagnostic Ventana. And they have their respective antibodies. So we are using at RGCI this pathway for utilizing the clone 4B5 from the Roche Diagnostics. And FDA has approved this pathway assay companion diagnostic for the HER2 low breast cancer and ultra low to receive the FAM trastuzumab deruxtecan. So when I talk about the FDA approved assay, it is not just about the antibody or the platform. It is the incubation time of the antibody, even the chemical reagents, their pH, the antigen retrieval procedure, duration of each step, chromogen, amplification step, whether you are doing amplification or you are not doing amplification, and temperature control. So these are the integrated, sequential, and complex series of chemical reactions that gives you the end result of the HER2 membranous staining in the tumor cells. So coming to the HER2 scoring in the breast cancer, so the criteria for the positive, that is the 3+ HER2, is very crisp. You have to follow the triple C. That is, it has to be a complete, circumferential, and chicken wire. That means you have a thick membranous staining. Anything less than 3 is 2+. So here you can see this is a circumferential staining, but it is not thick chicken wire. Although very few cells are showing this thick chicken wire staining, but we cannot cherry pick these cells. It has to be a continuous also. As I have said, the triple C, continuous, circumferential, and chicken wire. So this is the case of a equivocal 2+, and then which was subjected to the FISH, which was found to be eventually amplified. So we have to put an addendum once the FISH results come. So we have to put the addendum that the final interpretation is HER2 positive. This is another case. Here you can see a very thin membranous staining, which is circumferential and complete. Again, it qualifies for equivocal 2+, but subsequently the FISH was not amplified. So we have to put an addendum to the report that the final interpretation remains HER2 negative, HER2 low. This is score 1+, negative HER2 low. You can see the membranous staining over here is actually a very incomplete membranous staining. So it is not a circumferential staining. This is ultra low. So this was recently I got the case of a metastasis in the lung, and it was actually 0+. So here at this magnification, you cannot find any staining. You cannot appreciate any staining. Even I cannot appreciate. But in this area, when this was seen in the high power, so you can appreciate there is some incomplete membranous staining in very few cells. So this was for 0+, ultra low. Now this is very important if there are pathologists in this forum. So the right microscopic lens is very critical to accurately assess the HER2 IHC score. So HER2 3+ and 2+, they are quite easily visible at the low power, but for HER2 1+ or ultra low, they are not observable at the low power magnification. So they are best visualized at 40x. So you have to diligently look for the ultra low staining at the high power 40x. So these are the new reporting categories. So which I have already reinstated, that the score 0 has now been dissected into HER2 null and HER2 ultra low, which is score 0+. So whenever there are changes in the reporting algorithm and changing in the guidelines, it is very incumbent upon us, to publish our own data. Like this was the first study from India we published when there was a major change in the 2018 ESCO-CAP guidelines on reporting FISH in the IHC and the reflex FISH categories in the breast cancer. And there at that time we found a substantial decrease in the equivocal cases and in the reflex FISH reporting. With the adoption of the 18 guidelines, a total of 5.6% cases from equivocal and positive cases, actually they shifted to negative FISH result. That was highly significant, and there was an elimination of the double equivocal cases. So what are the practical challenges in the HER2 low and ultra low reporting? Coming to the choice of sample. So many times I get the queries from the clinicians also whenever I get the blogs for reviews or for the HER2 low and ultra low. So any sample with the HER2 low or ultra low makes the patient eligible for trastuzumab deruxtecan. Testing any available sample to obtain at least one with the HER2 low or ultra low might be essential when the patient has no other treatment options. The core needle biopsy has advantage of the optimum fixation and the best result. However, it has a limitation of the limited sample area. And we all know that heterogeneity of a HER2 is a problem. So heterogeneity of the HER2 staining is best taken care in the excision biopsy. Regarding the repeating the HER2 IHC stain in the subsequent excision biopsy for the cases with the HER2 zero in the core needle biopsy increases the number of patients which are eligible for trastuzumab deruxtecan by up to 42.1%, as the data has been come from the results from the various studies. However, if given a choice, the recent sample metastatic should be the preferred samples, because you can have a upregulation of the HER2 status. The sample which was initially negative, maybe even positive also 3 plus. So definitely if the score was score 0 in the initial biopsy down the line, 3 or 4 years back, so this time it may even show score 1 plus, 2 plus, and even a 3 plus. So samples from the bone metastasis should be avoided as far as possible, especially if they have been subjected to decalcification, because the harsh chemical reagents can actually, it downregulates the expression of the HER2 membranous staining. Coming to the choice of the platform, since FDA have approved the HER2 low protocol using the pathway anti-HER2 for trastuzumab deruxtecan, and if the previous sample has been tested using a different protocol or a different platform or antibody, so a retesting is mandatory, because for this drug to be given, you need to have a companion diagnostic. And studies have shown that Hercept test, that is from the DECO kit, they show more staining than pathway, which is a companion diagnostic. And hence, if the testing has been done on a DECO platform, you will pick up more HER2 low and ultra low, but whether they are going to give a clinical response, that is not sure, because we should use the companion diagnostic assays, because they are the ones assays that has been clinically also validated. So, and this was a study by Rushoff et al., and they have shown that the 37.5% of the HER2 zero cases which were tested by 4P5 Ventana, which is a companion diagnostic, they actually turned out to be HER2 low when they were tested with a Hercept test by DECO kit. And this is a very good article, and I recommend all the students to please go through this article, that filling the gaps of examining the HER2 low and ultra low in the breast cancer, which is the full text is freely available in Archives of Pathology, Lab and Medicine. So what are the pressing issues? So what are the best assay to identify the HER2 low or the ultra low? Since the conventional HER2 IC was developed to distinguish the HER2 positive from the HER2 negative breast cancer, and moreover, the preliminary results of the phase 2 trial, DAISY, reported that the 30% of the HER2 zero breast cancer, they also responded to trastuzumab deruxtecan treatment. So are we really dealing with the best predictive assay, as Dr. Krupa Shankar also alluded to this point in his talk? So even the stalwarts like Dr. Kimberly Allison and Dr. Wolf has actually addressed this issue, and they are the authors of the ESCO-CAP recommendations for HER2 testing, whether this is a very accurate or the right assay. And even the authors of the Destiny 04 trials, they have also actually, they have raised the question regarding the accuracy of the HER2 low scoring. However, the PFS benefit was observed in the patient with HER2 1 plus and 2 plus ish negative. So given the reported limitations, the alternative quantitative methods to better select patients for this new therapy may be warranted, and as the minimum HER2 expression threshold required for trastuzumab deruxtecan activity is also currently being undermined in certain other ongoing trials, these results could have implications for the future selection of the patients for the trastuzumab deruxtecan treatment. So to conclude, the encouraging results from the various trials supports the potential for expanding the role of HER2 targeted therapy across variety of HER2 expressing solid tumors, besides breast cancer also. And the treatment landscape for the HER2 targeted treatment will continue to expand. The HER2 testing in breast cancer and other cancer will also continue to evolve. Applying the appropriate scoring method and following the reporting guidelines will be prudent. Participation in the EQUAS, that is the External Quality Assurance Scheme, and proficiency testing would be invaluable for reassuring the lab performance by the pathologist. And it's incumbent upon pathologists to make the testing reliable by optimizing the pre-analytical, analytical, and the post-analytical steps. Thank you very much. We'd be happy to take any questions.
Thank you so much, sir. And obviously, you have been bang on with the points about HER2 low and ultra low. So these are the new things, and all the students need to remember that the HER2 definition is going to be asked in their exams, whether in the form of practical, in the form of slideshows. So they need to be well versed. And obviously now it has a major amount of predictive role as well, as we can see with the availability of TDXD. I think sooner or later we might be adding NGS to the arsenal of patients who are having, HER2 low or ultra low as well. Maybe ERBB2 amplification will be able to guide us over there as well. So any case that you recommend or any situation where you had an experience? Okay, initially it was HER2 new negative, and it turned out to be HER2 new positive, and a vice versa, where initially HER2 3+ was there, and it turned out to be HER2 new completely zero. So any in your experience, what all medical oncologists should remember from your experience?
So what I have learned in my experience at Oncology Center in last 16 years, that as you have rightly said, that you can, which is characteristically known as a phenotypic switching. So the IC changes from over a period of time. So what I have seen, that the upregulation, and the literature also supports that the upregulation of HER2 is common, and downregulation of ERPR, that is a hormone, is common. So if the patient down the line, 3-4 years back had a HER2 negative, it can very well be HER2 positive. So that is why there is a recommendation that whenever there is a metachronous tumor deposit is there, or there is a metastasis, so both the hormone as well as the HER2 testing should be repeated on the metastatic sample. So the upregulation, the initially which was HER2 negative, you can very well have a HER2 positive subsequently on the mets. And similarly, for the hormone receptor status, if that tumor was initially if that tumor was initially ERPR positive, it can very well be ERPR negative on the subsequent metastasis. The vice versa is rare, although they do happen, but that's quite rare.
And again, thank you so much for teaching us. And it's always lovely to have you on all the academic feasts that we plan with you. And you have been amazing. And thank you so much, sir.
So there is one question is that from Karthik, that is there any role of re-excision biopsy in HER2 testing in HER2 low and ultra low in the first time setting?
I don't think so. I think if one has given a HER2 low or ultra low in the first time setting, we just take it. We don't reconfirm it.
Yeah. So the point to be taken is that if suppose you have a HER2 zero in the core needle biopsy, but if you have a resection specimen, then there is a point of doing a retesting again in the excision specimen, because of the heterogeneity. You may have areas in the excision specimen which was in the core needle biopsy that was not being taken up due to heterogeneity, but in subsequently excision specimen you can have the areas of HER2 low or ultra low. But if you have already in the biopsy showing low or ultra low, as Dr. Aditya has also alluded that, so there is no point of doing a repeat testing in the re-excision.
Okay. So if a patient is having ERPR positive and HER2 new negative in the biopsy, you would be tempted to do the HER2 new on the final specimen, if I'm not wrong.
So that depends upon your intent of treatment. Suppose if you are planning for a trastuzumab deruxtecan, in this case, definitely there is a point of doing a retesting in the excision specimen, because HER2 has a great heterogeneity in the tumor.
So currently, trastuzumab deruxtecan mostly it's there in the metastatic setting. And
Exactly.
whenever we, contemplate surgical specimens, I mean, down the lane with the evidence which is going like DB09, I think things will move ahead into the terms of curative setting as well. So again, what about RGCI? If you have a patient at incurable stages, if the patient is having, let's say, triple negative or hormone positive breast cancer on the initial biopsy, and then post NACT or post surgery, do we repeat again IHC markers, or do we just take the co-needle biopsy markers as the sacrosanct?
So that's a very good question. So if you see a difference in the histomorphology, suppose the tumor initially it was just a low-grade tumor, hormone positive, but in the subsequent specimen you find a tumor having a high-grade morphology. So even the ESCOCAP recommends that you should do a biomarker repeat testing in these cases.
And if it is the same, then we don't do, right?
So we don't do routinely. It depends, but we do get requisitions. But that comes from the
it's the attempt of a medical oncologist to make
Yes.
sure, to be doubly sure in select
Yeah.
subgroup, but not in everyone. So I
So
think
it's not
that
a protocol.
was,
Yeah, it's not a
that's
protocol
not
at
the
our
protocol.
institute to do a mandatory repeat testing, but it's the prerogative of the medical oncologist who gives the requisition in that case.
Yeah. Thank you. And thank you so much, Roshni. Please move on to the next because we have fantastic academic fees lined up. So we should move ahead in the next one. And one of the favorite molecular oncologists of Pan India, Dr. Aparna Dhar. And I think Roshni, you can introduce her better than me.
Thank you, sir. Now let's move to role of precision oncology in breast cancer by Dr. Aparna Dhar, ma'am, Director of Hereditary and Precision Oncology Services at Max Institute of Cancer Care. Ma'am, over to you, please.
Thank you. Good evening, everybody. First of all, so sorry, and thank you, Dr. Pastricha, for going before me. I really appreciate that. I'm very quickly going to share my slides. Whoops. Okay.
And ma'am, please give some pointers to us medical oncologists as well that we should all be learning from you in the very initial stages of our careers so that बड़े हो गए हम आपको तंग कम करें.
नहीं तंग क्या करो वो तंग में क्या होता है कि हम लोग एक दूसरे से सीख लेते हैं ना वैसे तो सीखते हैं.
So I don't want our students to do major, bunch up in the examination. So obviously at the end of your slide, I want few pointers that, every oncologist before coming out into the practice, these are the few pointers from the precision oncology perspective that they should know.
So I'll start with that. Befriend a molecular person, a molecular geneticist, a molecular oncologist, befriend them. Please know that we're there as auxiliary support to make you look good and to help you in your clinical practice. So find one, build a rapport with them, and know that we're there to support you. Today, when we do precision oncology, we all have to work together. It's not a one-person show. It's a combination of multi-specialities. And by the time a lot of you students are going to come into practice, there are going to be proteomics, and I don't know what is coming about, and oncology is changing. So learn to work in a group. You can know you learn to work in a team, learn to work in conjunction with different individuals from different specialities, because you will always be the face for the patient. You will be the person the patient trusts, but at the back to help you have better outcomes with your patient care, you need people not just like us, but a lot of similar background people working together. So I think for me, my key takeaway with everything is we can all speak and do whatever we have to do. But at the end of the day, it's a combined effort. If today I can stand here and talk in precision oncology, if I can present cases, it's because I work with fantastic medical oncologists who work in conjunction in supporting the precision oncology clinic. So on that very optimistic note, hopefully, let's get started. So I've been given quite the task today to talk to you about precision oncology in breast cancer. So whenever we think about the role of precision oncology, we need to ask ourselves the first question. Just to confirm, my slides are moving, right?
Yes, ma'am.
Okay, cool. Thank you. Okay, so the first question we should always ask ourselves when in any solid tumor is there any role of profiling? So before we talk about precision oncology, what is the role of profiling? So today my topic is breast cancer, be it advanced, be it metastatic. Let's understand that. Number one, very basic view of patients with breast cancers. We know they're classified as per their ER, PR, HER2 new status. HR positive is the majority in our country. Triple negative is definitely more than 15%. And then you've got, a very typical HER2 positive breast cancers. But honestly, if you look at it today, we've moved beyond the very interesting intrinsic subtypes, such as your HER2 positives, your luminals, your basal subtypes. So you're starting to look more at the genomic drivers. And we've gone beyond the simple classification. We're looking for alterations in PIK3CA pathway. We're looking for alterations in DNA damage repair pathway, resistance mechanisms in ER signaling pathways, growth receptors like your FGFRs, which could potentially allow us to target in a more precise way. And I think this is a very beautiful study that illustrates the molecular landscape of breast cancers being heterogeneous. So as you can see with each subtype, be it the HR positive, be it triple negative, there are a plethora of somatic aberrations that can occur. And if you actually compare the difference between the primary and the metastatic site, there are at least 9 driver mutations genes that were seen there. And TP53, ESR1, AKT were frequently mutated in your HR positive metastatic breast cancers versus your early. And then again, if you look over here, metastatic triple negative breast cancers actually showed an increase in the frequency of biallelic loss of function in genes that were, genes that were related to homologous recombination repair. And your metastatic breast cancers also showed an increase in the mutation burden and obviously clonal diversity as compared to your early breast cancers. Long story short, they are heterogeneous diseases. Now, the poster child for molecular profiling, molecular oncology treatment has usually been lung cancer. So I'm going to implement something similar here with breast cancer. These are, again, just my views. So going back to the basics, a very simplistic view of patients with breast cancer is this flowchart essentially, alludes to the fact that you only have 3 biomarkers, ER, PR, and HER2/neu. 2, it says that the biomarkers stay static. We know that in about 30% of patients on progression, there can be a loss or gain of function. We just heard Dr. Basricha talk about it a little bit earlier. And it also assumes that there's only one activated pathway that is dominant. Again, we'll see with a bit that actually it's a crosstalk between multiple pathways. So let's begin with the triple negative subtype. Now, if you look at the tumor biology of triple negative, right? We know them as typically being associated with the worst prognostic outcome. And you can see from this heat map here that the patients with triple negative breast cancer, it's not as simple as we think it is. So even amongst this group of patients, we see subtypes like your luminal AR, your mesenchymal, your basal immune suppressed, basal immune activated. And among each of these subtypes, we again have very different treatment strategies. So for immunotherapy is there for your basal immune activated subtype, but PARP inhibitors are there for those with alterations in the DNA damage repair pathway. And again, all the genes in the DNA damage repair pathway are not the same. So we're talking about the BRCA1, BRCA2, and the PALB2. And then you have immunotherapy combinations in your basal immune suppressed subtype. And of course, a very simple IHC marker for looking at AR, especially if you've got luminal AR, so you can actually treat with anti-androgen therapy. So not a very simplistic view. Whoops. Now, here's what I think is the very optimal molecular diagnostic algorithm that is there for our patients with triple negative breast cancer. You can either treat the defects in the DNA damage repair pathway where you've got PARP inhibitors and platinum chemotherapy, which have very clear roles, or you could treat the inflamed phenotype, which is immunotherapy. We know that has a very clear role again. And the AR pathway, which is simple IHC marker that can be done. And we have, again, agents for it. And then you've got alterations that occur in your PI3K pathway. You've got alterations that are, with your AKT, we have AKT inhibitors for that. And last, but definitely not the least, those agnostic markers, don't forget about them. Your NTRK fusions, your RET, which I know is an orphan drug status. And in fact, there's so much more data coming out. Did you know that EGFR T790M, which we tend to see in our lung cancers, actually also having an indication in triple negative breast cancers? So this algorithm is actually forever evolving. Now, if I move over here and let's look at our, let me look at my the HR positive subtype. Now, if I look at the HR positive subtypes, again, very, very straightforward. You have your ERPR. Now, in the presence of an ESR1, we cannot use agents such as aromatase inhibitors. They don't work very well. So you need to look at agents such as fulvestrant. Again, in the HR positive, there can be defects in the DNA damage repair pathway where a PARP inhibitor can work. And then we've also looked at the AKT pathway, the PIK3CA, mTOR, and your agnostic markers. But for me, and I've just again further gone and simplified it to how we practice in our, what we see in our clinical practice today. But for me, what's really, really important when it comes to our hormone positive is this particular diagram. What this diagram is essentially doing is that it's pointing out that from the very beginning, I said these are not static, right? So when we are looking at these, there's always crosstalk between different pathways. So what I want to focus on is actually this. It's a very simplified version of looking at the cell cycle pathway. Now, this triangle essentially emphasizes the 3 most important nodes that's in the signaling network. So on one hand, you have the estrogen receptor, your ER. On the other, you have your CDK4/6, and then you have your PI3K pathway. So whatever you do, the ER positive breast cancers will have one of these angles that are going to be activated. So what we actually try to do is that if you block the ER pathway, the PI3K and the CDK4/6 act up. If I go and block one angle, the other nodes start to act up. So that's why if you logically think about it, even if you're giving a PIK3C inhibitor, you never give it standalone. You give it in conjunction with some sort of therapy. You give fulvestrant or chemo if required, but usually it's fulvestrant with alpelisib. Your CDK4/6 inhibitor, while given on its own, but somewhere along the way, there is going to be resistance. And that's one of the key things that we're starting to see over here in our hormone positives. So when you're treating your hormone positives, remember this, that when you are treating one node, another node is definitely going to act up. It is going to go ahead and get overactivated. And this triangle actually, for me, shows the new age clinical trials now that are developing, where you have various doublet and triplet therapies that are coming together. There are some, I can't remember the name of the drug that's recently come up, but there are some new therapies that have come about that are actually going to be blocking all of this. So this is what we know, and this is actually ESMO that has come out with a scale that we know with the SCAT scale, which looks at the molecular targets specifically in breast cancer. And as you can see, there are various levels of evidence over here that we're looking at. So you've got your HER2 amplifications, you've got your BRCA mutations, your PALB2 also should be here, your PIK3CAs, MSI, NTRK, ESR, PTEN, AKT. A word of caution, whenever your patient is progressing, we have been burnt in the past where we've not checked the ER/PR HER2 statuses. So if you feel that the biology is changing, you are going to be doing a repeat biopsy at any point. There's no harm in going ahead, especially when your patient is not classically behaving as, let's say, HR positive as how they were. And maybe at baseline HER2 was 1+, 2+. Be on the lookout for that. It's very important because that's opening new lines of treatment. So while there is a lot of data, there's again some more over here where there are various targets which may not be directly telling you about treatment, but are actually the way the tumor is communicating with you. I know in the presence of, let's say, an RB1, which I'm going to show you right now. So some of the most common resistance mechanisms you are going to see in your hormone breast cancers, for example, hormone positive breast cancers is ESR1. You can be seeing this at baseline a lot of times. And as I said earlier, if this is there, you do know that your patient is not going to be responding very well to aromatase inhibitors, which means you need to change treatment lines. Another very important one is RB1. This is a known resistance mechanism that comes about when a patient is treated, especially on a CDK4/6 inhibitor. So if you do have this at baseline, you know your treatment is going to be short-lived. This is an acquired resistance to CDK4/6, but now with the advent of liquid biopsies, we are picking this up even right from the get-go, right from the beginning. So sometimes what we do know, and this was a very nice CGP study that was done way back in the day, and what they tried to do was they looked at the various pathways. So they said, all right, let's just look at everything, right? Let's not just be focused on the very classical ER/PR HER2. Let's go a little bit beyond. And as you can see, the more we tend to profile, the more we tend to understand the various pathways, the crosstalks, it opens up lines for treatment. Albeit you may not have data, but in precision oncology, sometimes you can have anecdotal case studies, or you can extrapolate information from another solid tumor and bring it here. But again, tread with caution when you're doing that. And that's where studies like this do help us in kind of illustrating the importance of it. So see, again, I've just used a basic algorithm of taking information from everywhere and showing you that there are multiple treatment options that are available. And a lot of this gets captured using NGS. How do we test for this? We use tissue biopsy. If tissue is not an option, I actually today want to spend some time on liquid biopsy in breast. Tissue, been there, done that. We all talk about testing with tissue, but I do think liquid biopsies, especially how heterogeneous our breast cancers are, can be beneficial. Now, when I'm talking about liquid biopsies, in particular, I'm talking about ctDNA, which is the somatic DNA that gets discarded into the bloodstream that gets isolated. So ctDNA, it's not CTC, it's ctDNA. And one of the key reasons for this is we're all very aware of tumor heterogeneity, be it intra or inter-tumor heterogeneity. And this does seem to be a problem. So mutations like your PIK3CAs, your ESR1s can be there actually at baseline. But because we're just taking a part of a tissue and getting it tested, a lot of times we do tend to miss out on potential targets. And again, there are a host of, host of potential applications where we can do liquid biopsies, especially in breast cancers. But for today, I'm just going to be sticking to what my thing is, which is with genomic profiling. Now, a very important question that we always ask ourselves, right, especially when we think CGP, do I need to do it in breast cancers, is what is the clinical utility and the benefit that we're looking at? So this was a very, very nice study that was called the MIRROR study. And I think this was way back in 2019. Yeah, this was pre-COVID. It was 2019. And what they did was they tried to see the benefit of ctDNA in metastatic diseases versus just profiling the primary tumor. And this is a question I get very often in my clinic. Should I profile on the primary tumor, or should I do a new biopsy, or should I do liquid biopsy? And this was one of the key objectives of this study. Now, they evaluated the concordance of genomic variants between the primary tumor tissue and the ctDNA in a metastatic breast cancer patient. And what the authors found was that, yes, there was a lovely concordance of 97.2%, but there were 13 variants in the metastatic tissue and the ctDNA that was not present in the primary. So the liquid picked it up. So ctDNA was definitely not inferior to tissue testing over here. And again, another great study that looked at liquid biopsies, which gave you the entire genomic landscape of these cancers. These are around 4,400 genes. And the most common is TP53, which is classical. We were expecting it. PIK3CA, ESR1. Surprise, surprise. You've even got an EGFR. You wouldn't have thought of EGFR in breast cancers, but that's the benefit of profiling. And in fact, I do know in some cases where we have had T790M, we have treated them with osimertinib and they have done well. It's standard of care? Absolutely not. But I did think this was a very, very interesting paper worth reading. Now, here was another very interesting study which looked at the landscape, and what they did, 105 patients were there. All of them underwent liquid biopsy with Guardant, but the tissue, 54 did it with Foundation and 44 did it with Tempest. And what we saw was that PIK3CA on tissue was around, the pickup was around 7.6%. However, on liquid, it was around 11.4%. Similarly, ESR1 on tissue was 3.8, and on liquid, it was around 11.4. That's a massive, massive difference with ESR1 in particular. Another phenomenal study that came out was the PlasmaMat study. It was one of the largest studies with respect to breast cancer, where they had 5 cohorts. And in these 5 cohorts, if I actually go ahead and I look at them.
Sorry to interrupt you, ma'am.
Yeah.
The time is up. Could we wind up, please?
Sure. Just give me 2 minutes. I'm just finishing. This is the last study and I'm just going to finish. All right. So we had 5 cohorts, and based on the ctDNA testing, they went ahead and they did treatment based on the NGS reports. Now, what was the key takeaway over here was that even when we do liquid biopsies, NGS was superior to, let's say, a digital PCR. So the treatment responses are being monitored, and we did know that those who were molecularly matched did obviously much better than those that were not. Again, another fantastic report over here, head-on-head comparison where ctDNA was not inferior to tissue. This was again seen in real time. And this is what I was talking about earlier, that a lot of times we do tend to miss out. We do tend to miss out on potential mutations that could be lurking at baseline. And this, this was a very nice case study that showed it in a patient that the ESR1 mutation was there from baseline, but tumor picked it up much, much later. Again, a head-on-head comparison. And in the era of PARP inhibitors and platinum therapy, please be careful of BRCA reversions. BRCA reversions are when you have a mutation in your BRCA1 or BRCA2, and it inadvertently somewhere goes and restores its protein function, if not completely, partially, and goes from being mutant to wild type. And that's why your chemotherapy or your platinum chemotherapy doesn't work, your PARP inhibitors don't work. There are new tests that are coming out, like methylation studies, where we can look at these genomic alterations, which can also help make treatment decisions. And very quickly, the last one, I'm going to actually skip through the cases because I don't have time, and I'm going to stop talking. And if you have any questions, anything, I will help answer those. Sorry, I didn't realize I overshot my time.
Yeah, but then again, even we wanted to listen more to you. So,
No, I'm so sorry.
So, okay, given the choice, a patient comes to you and to us, They say that finances are not an issue and it's a curative setting in CA breast. Everything like, let's say it turns out to be a luminal B. So the question is very specific. Do I need to get an NGS on the somatic? First question is, do I need to do NGS upfront? Second, whether to do NGS on the somatic or liquid. So because there are a lot of students here, so we need to give them the answer as per the current standard of care and what the future holds in the upcoming years.
So let's start with the basics because we've got students over here. Upfront in India today, the current practice in breast cancer is we're not doing any profiling. Based on the ERPR HER2 status, we go ahead and we start treatment.
Right.
The role of NGS in our clinic in breast cancer today happens when there is progression or the patient's tumor is behaving weird, odd, it's not behaving as it's supposed to be behaving. Then at that point, I think is where we tend to see NGS coming in today, as of today, July 2025. Do I think this is changing? Absolutely. I can start to see where cost is not an issue in metastatic breast cancer in particular. We are slowly starting to do testing. At baseline, we are starting with somatic on the tissue. And then on progression, we are doing liquid biopsies. So the question I will always ask is, before we go liquid or tissue, is what are we trying to find out? So that's a question you should always ask yourself. When you do NGS in any cancer type, what is my aim? So if my aim is that my patient is going to be starting a CDK4/6 inhibitor, I want to be sure that there is no lurking RB1, NF1, FGFR, any resistance mechanism, because your patient is going to ask you, if I'm going to be spending so much on a CDK4/6 inhibitor, how great is my outcome going to be? And today, in the era of ChatGPT, your patient has already done a ChatGPT search and has come to you and tells you about these resistance mechanisms. So a lot of times at baseline, we are starting to see a trend, and I can see this changing, where we are doing somatic testing at baseline just to get an understanding as to what the biology of the tumor is. It's yet not standard of care, but it's a small change in practice that I have seen in the last year or so where we are doing this.
Right.
Second is that if we've not done any NGS at baseline, the usual trend is on progression than to do NGS. At that point, I would say do a liquid biopsy, because we are seeing that breast cancers are heterogeneous and we have been burnt in the past. In triple negative in particular, I couldn't spend too much time on it, on a particular case, but in triple negative in particular, we've treated the patient with platinum chemotherapy, germline BRCA2 mutation, worked well on platinum, went through everything, started on PARP inhibitor. In less than 4 months, she progressed. And we couldn't understand what was happening. So we did testing. First, the somatic tissue was done on the new metastatic site. Came back negative. Nothing major was there. And we just got that BRCA mutation. Obviously, something was going off. The patient was resistant. So we then did a liquid biopsy. And this is where I've started to prefer liquid biopsies, because liquid biopsies can help pick up BRCA reversions. So in your NGS report, what you will see is that somatic mutation, which is originally a germline. So you'll see one mutation which has a VAF of 45, 50%, 60%. And then next to it, you'll see a series of multiple small BRCA mutations. Go back and ask the lab. If they're anywhere near each other, it's most likely a BRCA reversion happening. And that's exactly what happened in that case. The patient's tumor somewhere had figured out a reversion. So in that case, I would definitely do a liquid biopsy. So I think take home would be, if it's triple negative, progression, post-platinum, post-PARP inhibitor, do a liquid biopsy. Tissue you will need for ERPR HER2 status. I would not depend on NGS for that. NGS would be beneficial at looking at ERBB2 amplifications, which is essentially a HER2. Anything greater than 6 means it's targetable. But still, even if it's on liquid biopsy in particular, if it's greater than 6, if I have some element of tissue, I will do IHC. I will get a confirmation. That is still my gold standard if I have to switch to, anti-HER2 therapy.
Right.
Yeah, Dr.
Again,
JC.
fabulous and
I-
fantastic. The same. Yeah, Dr. JC, yes, go ahead.
Yeah, I just listened to half of the presentation. It was a wonderful presentation. So if I have missed the talk, what is the take on ESR1 mutation, which is the most talk now, the ESR1 mutation monitoring by liquid biopsy in patients with metastatic breast cancer, and recently we have data to monitor this ESR1 mutation and at appearance of clones, whereas change to fulvestrant or the newer things which is not available like imlunestrant, not.
Elacestrant may not be available, but if cost is not an issue, and forget cost for 2 seconds, you can just do ESR1 by ctDNA testing. You don't have to do a big panel. A lot of our domestic partners do a single gene, which is ESR1 on liquid biopsy. I do feel it's beneficial, doing it at baseline and just kind of monitoring the ESR1. It's cost effective too. Now, at baseline, you will do your standard of care treatment. So if my ESR1 mutation, let's say a clone is there, and let's say it's sitting at 0.01%. I'm not going to really act on it. I'm going to continue my standard of care. But what I am going to do is I am going to do serial monitoring to see if that ESR1 is slowly rising. And you will see it. You'll see it on your PET scan. You will see the patient, clinical feedback from the patient, and you will see this rise. So upfront, even in the presence of an ESR1 clone, I don't think treatment would change. We would still do the standard of care. But because we know it's there, I think the frequency with which we'll monitor treatment response radiologically and based on liquid biopsy, I think that is what I would increase. So we tend to do this in a couple of cases. If it's positive, I repeat it every 3 months. And I just do a basic small, and I just do a single gene NGS, which is around 6,000-7,000 rupees. I don't do any fancy testing.
How deep you want to sequence in that case in the ESR1 mutation?
So these guys sequence it as high as 20,000x. For liquid biopsy testing, if you are doing for liquid biopsy, so all the studies that I showed that had concordance with tissue, the depth of coverage has to be a minimum 15,000x. Anything less than that, you are setting yourself up for a lot of false positives and false negatives. Especially false negatives, you're going to see a lot of errors. So when we say liquid is not inferior to tissue, that is because the depth of coverage, and that's a very good point, and I missed out saying this, is that it has to be a minimum 15,000x.
So, Dr. JC, I have to ask ma'am to have a final closing word because the next 2 panel discussions are waiting. And again, Dr. Aparna, you have been fantastic and fabulous both at the same time and giving fantastic information on how the precision oncology is on the move. I think it's moving even faster than the medical oncologist perspective. So with this, I thank you. And back to Roshni. Yeah, so you can continue with the further agenda. Thank you so much.
Thank you, ma'am. Thank you for your presentation. We now move to our first panel discussion on management of HER2 positive breast cancer in second line. This discussion will be moderated by Dr. Rajkumar Ramaswamy, sir, consultant medical oncologist at Vellamal Specialty Hospital and assistant professor at Madurai Medical College, Chennai. And we have an eminent panel including Dr. Jayachandran, sir, consultant medical oncologist, hemato-oncologist at Apollo Cancer Center, Dr. Vijay Guru, consultant medical oncologist and hemato-oncologist at VS Hospitals, Dr. Nitin Raj Daniel, consultant medical oncologist and hemato-oncologist at AOI BMH Calicut, Dr. Uma Dangi Ma'am, senior consultant medical oncologist, Grand Fortis Hospital, Dr. Ani Kanchanba, assistant professor, St. John Medical College and Hospital, and Dr. Deep Shankar Pruthi, Associate Consultant at Department of Radiation Oncology, Sir Gangaram Hospital. We welcome you all. Sir, over to you, please.
Good evening, everybody. Thanks for the opportunity to have this panel discussion on management of head-to-head positive breast cancer in the second line setting. Except for Dr. Uma Dangi, rest of the panelists are present, I hope so. So I request the panelists to be on, switch on their camera so that we can have a lively discussions. Please, Dr. Vijay Guru, could you please switch on your camera?
Right, sir, on the drive, so I'm kind of finding it.
Okay, fine. Can you see my slides?
Yes, sir.
Yes, sir.
Okay. So today we are going to see in 25 minutes or so, we are going to see what is the management of HER2 positive metastatic breast cancer in the second line. So this is a case, 39 years premenopausal, a large ill-defined lump occupying the whole upper two-thirds of the lefters, HER2 IHC3 plus, ER negative, PR positive, multiple left axillary, left intrathecal, bilateral cervical lymph node with the extensive metastases on the lung, liver, and skeletal and the muscle deposits. So we'll go to the first panelist, Dr. Jayachandran. What will be a line of management? Of course, now the options are plenty. I have listed some 8 options. After that, the standard of care is one. Obviously, everybody knows is there, so is one. But I have included purposefully so that what we are having a insight into the future. We are having a plenty of options of plenty. We are spoiled for choices, and the options are going to be plenty. Many of the drugs which I have listed is on the pipeline and is on the trial, any part of the trial. The trials are not yet matured. So what will be your choice? The first line is the patient.
Number one, sir. As of now, it is THP would be my choice of treatment. But yeah, yes, absolutely.
Metastasis, lung, liver. So you like?
Yes, sir. I would go with this one. So what about the brain, sir? Is the brain metastasis?
We will move on to the Dr. Vijay Guru. If this patient has got extensive visceral metastasis, you like to image the brain?
Obviously, sir, we will image the brain also. And my choice, as JC sir told, it is THP again.
Even in an asymptomatic individual with an extensive metastasis, you will opt for an imaging of a brain in a HER2 positive subset?
If there is a suspicion, yes. If not,
the asymptomatic patient is totally asymptomatic, does not have any symptoms pertaining to
CNS. And your CT also doesn't show any information on a brain met, not to a MRI brain.
Okay, fine. Nitin Raj, Dr. Nitin Raj, are you there?
Hi.
Yeah.
Yes, sir.
What is the choice?
Sir, either 1 or 7, sir. 1 would be the which is the standard that definitely is there. 7 is again a TDXT plus pertussis. The data is still immature, but we can think about it. But I would start 1. THP.
Fine. So, Dr. Annie Kanchan, you want to have a better drug like TXD, which is on the pipeline, to be approved for the first line setting. Do you like to have a TXD more potent drug when compared to the trastuzumab, herceptins and all?
So, though TDXT is a very promising drug, I would also go with THP first, because I'm thinking, what if they progress later? I should have another potent drug in my pocket to use it later. So as of now, I'll use THP in the first line.
Okay. So I have listed the drug which are in the trial settings. It's a very early part of the trials. Some of the trials are ongoing, still yet to mature. So like your Destiny 09, Destiny 12, which are putting the TXD after in the first line setting. There are concepts to say that these patients do have higher incidence of patients who have extensive metastasis, do have higher incidence of at least 10% do have, even in asymptomatic individuals, 10% do have CNS metastasis. So why can't you try with the tucatinib at the front? These are all hypotheses, not a proof of the thing. So tuca has been used as to even in asymptomatic brain mets. So as of now, the SOC is THP based on the Cleopatra trial. As you know that HER2 amplifications and HER2 protein overexpression is associated with the bad prognostics, and it's also got a predictive value. And 10 to 20% of the patients of the breast cancers do have the amplification of the overexpression, and 65% of the HER2 positive MBCs are de novo metastatic disease. So as you can see, with these various anti-HER2 strategy, we have improved the 5-year overall survival from 30% to 58%. That's a real remarkable achievement we have made from 30 to 40% to 58%, 58 months of overall survival. We have now the options of plenty, and all the drugs are being tested in the first line setting. So, Dr. Jayachandran, you think the first line drugs makes today's topic is the second line. They determine which drug to be used in the second line. Do you agree with that?
Yes, obviously, see, first line, if you're going to use THP, obviously, when it is something which is going to influence the second line. But now with the availability of TDXD, I think irrespective of whatever you use, whether you use pertuzumab or not pertuzumab, TDXD would be the standard second line treatment, irrespective of whatever you are going to use, unless you completely avoid trastuzumab, which unfortunately doesn't happen anywhere. Mostly we at least use trastuzumab with chemotherapy or trastuzumab, pertuzumab with chemotherapy. Irrespectively, whether you use pertuzumab or not, TDXD is the second line treatment, or TDM1 is the second line treatment. Some we can prefer even the tucatinib also with capecitabine if the patient has brain metastasis. However, the data lacks in the second line. It's most of the time the data is in third line as of now. We don't have a direct head-on comparison with patients in second line versus tucatinib versus TDXD as of now.
So the Cleopatra have shown a clear-cut overall on PFS advantage. The TDM1, the second line settings of the Emilia Thalasha shown, also Camellia trials have shown, sir. So these patients, Dr. Vijay Guru, has
Yes, sir.
started on palliative chemotherapy with the THS based on the Cleopatra trial and completed 6 cycles. And the response was evaluated. It's a stable skeletal lesions on lung mets, where now patient has got a multiple metastasis in suprainfratentorial region with minimal perilesional edema. Consider is a multiple metastasis. So what do you want to do? Your question is, you want to rebiopsy, we don't have a surgeon here, neurosurgeon here. You want to do a rebiopsy, try to do the head-to retesting, or you consider this history continues to be patient already been exposed to a anti-head-to strategy, you want to retest head-to, or you want to continue with the second line management?
Sir, if biopsy was feasible, I would have done. If not, I'm not going to head towards biopsy. Rather, I would have changed the anti-HER2 management one.
Okay, now we'll go to the radiation oncologist.
So I would like to know if the patient is having symptoms for the brain metastasis, because that is one of the key points. Because if the patient is asymptomatic, I would still like to defer the brain radiotherapy, because of now we have
Patient
better
has got multiple metastases with the
Yes, but if he's symptomatic or asymptomatic, that's the
if he's
question.
going to be asymptomatic, you are going to observe the patient.
If he's asymptomatic, then I would like to defer the brain radiotherapy because of especially with the HER-CLIMB trial with the agents like tucatinib, so which has shown better CNS penetrability. I would still like to defer whole brain RT. If the patient is symptomatic, then we would like to do local therapy. Depending on the number of metastases, if it's feasible, we can opt for stereotactic radiotherapy, because nowadays whole brain radiotherapy is.
If it is just if the patient is symptomatic,
yeah,
very much symptomatic, you will subject the patient to surgery followed by radiotherapy, or we will go ahead with the radiotherapy upfront.
So it depends on the number of metastases. I would like to not be in favor of whole brain radiotherapy because of the long-term side effects. And if possible, subject the patient to stereotactic radiotherapy if it is feasible. If the patient has, say, leptomeningeal spread or something like that, then maybe whole brain RT. But then nowadays the concept has shifted from whole brain RT to more for stereotactic radiotherapy.
Consider the patient has got less than 3 metastases. What do you do?
Yes. Then stereotactic radiotherapy is very much feasible.
So I have a small difference in opinion.
Okay.
I leave away the types of radiotherapy I accept. But in a second line setting, when the patient has brain metastasis, I would not avoid radiotherapy even if I have tucatinib. Tucatinib does not induce CRs. These are not osimertinib and lorlatinibs, which induce CRs in brain. Tucatinib is, we will all see how tucatinib works in some time, really. Tucatinib is not a brain wonder. Okay, so patient with multiple brain metastasis, even if it's asymptomatic, I would go with the radiotherapy, and moreover, in second line setting, we still lack data for tucatinib. The data of tucline, he's in third line and not in second line. So I would still go with the in radiotherapy. But technique of radiotherapy, I completely accept it. The way the number of nodules are lesser, you can give stereotactic, or if the number of nodules are more, you can go with the whole brain radiotherapy. But as residents are here, there's no point in observing a asymptomatic multiple brain metastasis in HER2 breast cancer in the first line or in the second line.
Dr. Nitin Raj, what is your take on that?
Sir, I agree. Actually, tucatinib, we had tried for a couple of patients. We have not seen a CR. We have seen a decrease in the size of the lesion. So we would still not. We have to go for a local treatment, sir. Not tucatinib cannot be an alternative, sir.
Tucatinib is a overhyped drug. You will all see the results of tucatinib when you use it in another 1 year or two. I'll mark my words.
Dr. Adi Kanchan, if the patient has got a stable disease in the extracranially and intracranially there is a progression, it is a solitary or less than 3 lesions, what is your take on that? How you proceed? You want to subject the patient for a resection followed by radiotherapy, or you go ahead with the SRS?
Sir, I would, if it is less than 3, it's amenable for surgery, I will do the surgery followed by RT in that, to the cavity.
Radiotherapy, doctor?
So I feel that, I mean, with surgery, of course, there may be some delay with your systemic treatment. So, I mean, less 3 lesions, easily amenable to stereotactic treatment. You can safely avoid surgery. But yes, if considering the patient has, I mean, CNS disease, so I think, yeah, we can go for stereotactic radiotherapy.
What's an idea of combining an SRS plus bone pair RT? Is not advisable.
So I would again say whole brain RT is generally not advisable because of the long-term side effects in terms of cognition, especially. But now even we have techniques so that we can spare the hippocampus. But recently in ASCO, I think they had published that even up to 20 brain metastases, they are still advocating for stereotactic radiotherapy.
Is there
So I
any
would say
head-to-head comparison between hippocampal sparing for whole brain RT versus SRS? Is there anything like that? Oh.
there have been studies, but then in terms of cognition, still stereotactic radiotherapy is preferable.
So what
I have a small question, which may be controversial. See, what is the median time to have cognitive abnormalities in a patient after whole brain RT?
Generally, we say after a year or year and a half. So with the new targeted agents, we expect patient to have a longer survival. So that is why the concept of stereotactic radiotherapy is now taking over as compared to whole brain RT.
We can see radionecrosis following a whole brain RT. So nobody wants to rebiopsy and test the status, the molecular profiling or the IgG biomarkers for the HER2 status. Jay Guru, following
No, sir.
surgery?
Only when there is only intracranial progression, obviously not.
So SRS is whole brain RT. Definitely the cognitive deterioration-free survival is far better with the SRS when compared to whole brain RT. So randomized trials of the SRS plus whole brain RT in 1 to 3 brain matters cognitive deteriorations far better with your SRS when compared to the whole brain RT. There are trials, radiation oncology, there are trials with the SRS whole brain RT, but definitely is far inferior when compared to SRS. Am I
Yes,
correct?
sir. Yes, sir. Definitely.
Okay. So SRS alone is the treatment of choice before for patients with 1 to 3 brain metastases. Am I correct?
Yes, sir. Agreed.
Jay Chandra, now the patient has progressed on your Cleopatra type of protocol. Now what is the choice? Second line.
Leaving all the financial issues to TDXT.
TXT.
TDXT, provided the patient had a
patient has got a brain mets and the radiation
Yes,
oncology is very much urging for a tucatinib. So you don't like to have a tucatinib. What any
Sir,
comparison?
I already asked you. I've been telling this already. So basically, tucatinib.
Any
I've been
comparison between
telling
the
this.
intracranial responses with the neratinib, with the tucatinib versus TXD?
See, basically, they have not been compared head on head in the second line. Tucatinib plus capecitabine plus trastuzumab, or tucatinib with capecitabine with whatever things has not been compared with TDXD in the second line. We have data only in the third line with patients. We could not extrapolate. TDXD is a wonderful drug. It crosses the blood-brain barrier by very many ways because it's a very lipophilic molecule. It crosses the blood-brain barrier, provided it also had various data have shown that it has shown responses even in brain metastasis, but still, I would go for radiotherapy, whatever
But they say the
SRS or
TXD
the
is
whole brain.
associated with 15% ILD rates.
So
and the
carefully
incidence of
monitoring the ILD
neutropenia.
nowadays, I think nowadays after careful monitoring of lung functions, see getting a routine HRCT after 2 to 3 cycles of TDXD, we could clearly see that we can easily pick up those patients very early and stop the TDXD. The first trial which came out had a very high incidence, and all the subsequent trials had reported only a lower incidence of ILD,
So
which is about
what is the
7%.
preferred dosing, 5.4 or 6.5 mg per kg body weight?
We don't give, sir, because in our real world setting, TDXT of 5.4 mg per kg is very financially toxic for Indian patients. But as said, financially, apart 5.4 mg per kg, otherwise we give a routine of 100 or 200 mg. Flat dosing,
So I
still
request
they have a
everybody,
beautiful.
because right now a lot of students are there. Let's not dive into the discussion of financial dynamics. Let us just stick to the basics. Let's say if
It's
I
a
want
5,
to
it's a
ask this
5.4 mg per
question
kg.
in the Viva, I want a straight answer. I don't want to listen to, finances and all. I want to give the best option. And I think best
It's just
option.
5.4 mg per kg. That's all.
Exactly. That's the answer.
Fine. Dr. Vijay Guru, what is your second line option will be? You like to go with the TXDs based on the 03 trial, or you want to try with the tucatinib with the better intracranial response rates?
The intracranial response rates are good with the TDXD as well. And with the available data, with so much of differences in terms of PFS and stuff, I will stick on to TDXD with the proper dosing.
Anybody can have any experience with the neratinib? Anybody in the panel? Is it a good drug or a bad drug? Jaychandran?
It's a very worst drug. Once I had got it outside from outside and given, it creates a lot of diarrhea. I have only one patient for 1 month. It was a
I
grade
think
3,
in
grade
another
4 diarrhea.
few months we are going to have a lot of clinical trials available in terms of neratinib. I think maybe down the lane we'll get the the usual TKI learning curve with neratinib as well.
Yeah, maybe. I have a very bad experience. It's only
Neratinib
1
is
month of one patient.
Bad. Lab cap also, we have burned our fingers with lab cap.
But lab cap we have somehow managed.
Very bad. Very bad.
Lab cap we could manage the patient easily. But neratinib, as Aditya told, we need a lot of learning curve if at all.
Okay, fine. These we all know the TXD has got a better ADR when compared to the breast 03 trial Destiny plus 0 has shown the TXD has got a better PFS and overall survival compared to TDM1, and the baseline brain metastasis as well as in the presence of even the baseline brain metastasis, the forest plot curve shows a better response rate with the TXD upfront. So they say the ILD's ratios are a little higher, 15%, neutropenias, dyskinesia rates a little higher when compared to TDM1 in the breast 0. Pre-trial dyskinesia, dose reductions, drug interruptions are a little higher, grade 3 toxicity is a little higher, because you basically are giving a chemo drug in a more intratumoral and peritumoral fashion rather than intravascular compartment. So you have all the attendant complications associated with the alopecia, all your neutropenias, febrile neutropenias, and all we encounter with the TXD. But as Jaychandran says, you have to identify these patients with ILDs, and you have to have a dose reduction discontinuations is manageable. As you can see, the grade 1 and grade 2 toxicities are higher when compared to grade 4 and grade 5. So we have to be a little careful with the grade 3 ILD and pneumonitis. Tucatinib, of course, what is the role of tucatinib, Jaychandra? You put it in the third line after the progression
Yes.
on no role in the second line. Am I correct?
No, as of now. There are trials going on, but as of now, no.
Dr. Annie, what take on that? You will go with the TXD or the tucatinib in the
Yes, sir. I would go with TDXT second line and third line tucatinib because personally I've had good responses with similar patients I have had, and they've had excellent responses with TDXT. So I would place TDXT second, tucatinib as third line. And as Jayachandran said, the toxicities are pretty well managed. And with our serial CT chest, we can pick up ILD. So I did not have much of an issue with the ILDs, the percentages that they have reported here in the trial. In real world, it has been pretty well manageable actually.
Okay, but you are not using the dose of 0
Yeah, here I'm not telling the dose here because we give answers and
okay, fine. Then the head to climb has shown better response rates with the overall survival and PFS advantage in all patients with brain mets. As you can see, even in brain mets, they have a better, the curves are hugely separating into tucatinib with trastuzumab. Intracranial overall response, the duration of response in patients with active brain mets, as we can see, is very good with the tucatinib with the trastuzumab. This is very remarkable. Of course,
this is what I wanted to clearly tell, sir. Even CR plus PR is only 25%. That is why you should give radiotherapy.
Numbers are small.
Yeah, that's what I'm telling you. Even this is small numbers, it is only 26 out of not even if you look at CR rates, it will be far like 5 or 6. Okay. So that is why this will not induce CR. So please keep in mind they have a very good intracranial activity, but they do not advise, they do not go into CRs.
Jayachandran was talking, and they have very high amount of grade 3 diarrheas and nauseas and vomiting. And combination of tucatinib and DTM1, this head to climb 0-2 study design was there with randomization 1-to-1. This is placebo plus TDM1 is tucatinib plus TDM1. These are all in the yet to mature. These data are yet to mature combination of tucatinib plus TDM1. Third line setting patient has progressed on the second line of TXDs. Vijay Guru, you want the patient has progressed following Cleopatra protocol. Dr. Jayachandran, patient has progressed on Cleopatra first line.
I think
then
we
you
have
have
discussed
TXD.
third line. Third line is
you want to use a different ADC, like ADC followed by ADC, or you want to have a ADC followed by a TK. What is the any sequence?
I would rather go for tucatinib, trastuzumab, and capecitabine.
You don't want to use the TDM1 in the third line. Options are given in the NCC, and TDM1 is also now category 1 option.
It's still in third line. You have options of going for TDM1 versus trastuzumab, capecitabine, but problem is CDXT is a more powerful ADC. When it is failed, just by exposing another ADC, I would be a little bit skeptical. It is my personal opinion. I would go for tucatinib, trastuzumab, and capecitabine so that the patient would have an exposure of some form of chemotherapy in form of capecitabine and some form of TKI in form of tucatinib. That would be my preferential choice.
Dr. Nitin, what will be your optimal sequence using ADC for one ADC followed by another ADC with the less toxicity? TDM1 has got a very, very friendly drug, patient-friendly drug when compared to tucatinib. You want to go with an ADC followed by TKI.
It's not patient-friendly, sir.
This is definitely
TDM1 is not patient-friendly, sir.
It is very toxic, sir, and the fatigue is also very much there.
The thrombocytopenia and LFT functions.
Yeah, I would also prefer tucatinib combination, sir.
Okay, fine. So, any other newer drugs are on the pipeline, like your other ADCs are on the pipeline? So, you after 2 lines of progression, Dr. Deep Shankar, you want to redo biopsies now and trying to find out the discordance now, the head to status.
Yes, I mean, nowadays there is a role of doing a rebiopsy. So yeah, I think it should be done.
So there is a progression in the Now there is a progression in the CNS lesion. Intracranially, there is a progression. So you want to redo surgery, you want to open the cranium and do surgery and get the tissue, or want to do
No,
CTD?
no. Not for not for the cranium.
Hmm.
I mean, if there is intracranial progression, then I don't know. We've already exhausted radiation. We've exhausted the agents also. So maybe one of the newer drugs. I don't know. I think you guys are
So,
in a better
see,
position to answer
I
that.
would clarify this problem of biopsy. Basically, see, if the patient has a disease, a HER2 positive disease, just strongly HER2 positive, and progresses on THP without, like, within 6 months or 8 months, I think you need not do a biopsy again. But if the patient had a remission for a longer duration, like 2 years, and then if they had a progression, then you might need to go and check whether the patient is
Great
HER2.
point. The time frame by which you get the metastasis progressions determines
very
whether you have to
important.
go for a redo biopsy.
That's
If
a
it is going to be a
logical way
shorter
because
time, if it is going to be
yeah,
a shorter time, will you do it, Jayachandran, or are we going to be a longer
I
time?
won't do it. I won't do it if it's a very short time progression.
The NCCN recommends to
Say NCCN as a guidelines. We should be thinking logically here. Okay, we can't apply guidelines everywhere. They are not rules. They are guidelines.
Dr. Annie, we Indians try to use NCCN guidelines like a pickle. Wherever we like it, we take it. Wherever we don't like it, we throw it away. So you now tell me, Dr. Annie.
No, I won't do the biopsy right now here because they have progressed. I mean, this is 8 months after that it has progressed. It makes sense. I mean, logically, sir, and also when we have many a times we have seen that after giving HER2 based therapy, you will in the biopsy get a HER2 negative status, which I think has been encountered. This I'm talking about the neoadjuvant setting. When you give a HER2 based therapy, when they do the surgery and there is paths, I mean residual disease, and they do IHC, sometimes some of them ask for the IHC, they see a HER2 negative status. That time we don't stop giving the HER2 based therapy because it was negative in the post-op one. So here also logically, as sir said, if it has progressed, I mean within 6 months of me giving a HER2, which was IHC 3 plus, no point of doing a biopsy right now. But they've been stable, doing well for 3 years, 4 years, and then they have progressed, then yes.
But a lot of studies have shown that any patient who has been exposed to an anti-HER2, there is going to be a resistance mechanism. There can be a primary and a secondary resistance mechanisms comes in with the different pathways are being activated. So that's what guidelines talks about to redo biopsies. Nala trials has shown neratinib, but nobody wants to use an neratinib as such. So newer drugs, a lot of newer drugs are on the pipeline, which need is not available in India. Marketed and you have a special subset of a triple positive. Dr. Nitin Raj, if it's going to be a triple positive instead of an HR negative, you have to positive. What do you do in a metastatic?
Yes, sir. Sir, I would prefer the first one, sir, based on the patina report, sir.
Patina.
And along with it, like we'll go for the NGS also. Along with it, we'll look for the ESR. So we can do lots of things, but my preference would be definitely one, sir. Palbo plus Tras2 plus Per2 plus either a letrozole or a
Based on the
tamoxifen. Yeah.
Jayachandran.
I would also go with Palbo, Tras2, Pertuzumab with an AI or. So I would not think about Abima fulvestrant without an HER2 positive. See, if you look at, there will be a lot of tumor heterogeneity. Even if you go with an biopsy, if it turns to be HER2 negative, we will not be able to say the patient has turned HER2 negative completely because it is a very heterogeneous tumor. One area would be HER2 negative, another area would be HER2 strongly positive. So I would not think about not leaving out any form of anti-HER2 therapy. I would stick on to anti-HER2 therapy, add something like this.
So you preferably go with the. So Dr. Annie, you are not impressed with the Monarch Head trial results.
We are sorry to intervene, sir. We are about to complete the time. We request you to
fine. Okay, fine. The brain mets TXDs have been used in the brain mets industry. Breast 1, 2, 3. CNS activity, the TXDs are great. neratinib plus TDM1. So these are all the various trials which are in the pipeline. There was so much of drugs for the brain metastases, which are very active in the presence of the brain metastases, tucatinib, neratinib, lapatinib, and you have other combinations of TXDs, novel drugs, the combinations of anti-HER2 with the immunotherapy. TXD works in the presence of HER2 low, and the bispecific antibodies of the pipeline ADC, bispecific HER2 directed ADCs like zanidatamab. And this is what is called, how long will, if the patient is responding, Jay Chandra, how long are you going to give? The stop here trial has shown that if can favorably, the patient has got a good response and no progression for more than 3 years, you can stop the drug. Stop here.
I will not stop, so unless
You
the
will
patient has a
definitely.
cardiac.
Dr. Annie?
Unless the patient has cardiac failure.
This is shown. This is a trial design when the patient is not progressing, very stable, no progression. You can stop the drug at the end of the 3rd year.
But they advise all this MRD analysis and
Close
also.
monitoring versus randomization between stop HER2 close monitoring versus continue anti-HER2 close monitoring. So these are the various options in the first line, second line. As everybody told, this Cleopatra protocols in the first line, second line, TXDs, third line, TDM1 and tucatinib. Somebody wants to have a tucatinib rather than TDM1. ADCs followed by another ADCs. Of course, the resistance mechanisms going. So ADC followed by TK is preferable. Move after third or fourth lines is anybody choice. You can have many drugs on the pipeline. Thank you. Any questions?
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.
And thank you so much for such a fantastic panel discussion. And at the end of the day, again, whenever we are with students, I think cost we need to keep aside. We tell them just plain basic that these are the mistakes you can make in Viva. Kindly don't make it. And obviously, we just course corrected it. And obviously, if the indication is TDXD, then in second line, I think it's okay to just say TDXD. And if you have a brain tumor, I think then again you have so many other options, TDXD, then tucatinib, and obviously the plethora is going to open up with the availability of new ADCs like Dato and HER2 and zanidatamab. So it's going to be a very tongue twister times for medical oncologist. And with this, I thank Dr. Ramaswamy and all the fantastic panelists. And back to you, Roshni. Thank you.
Thank you.
Thank you, sir. Thank you to all the faculty. Now we move to on the last session of the day, panel discussion on management of HR-positive metastatic breast cancer, moderated by Dr. Aditya Sareen, sir, Program Director of the day, Medical Oncologist from Sir Gangaram Hospitals, with the panelists, Dr. Nitya, Consultant Medical Oncologist from VS Hospitals, Dr. Manikandan Dhanushkodi, Consultant Medical Oncologist and Director at Tutkodi Cancer Care, Tidmani Hospital, Dr. Rakesh Roy, in charge medical oncologist and palliative care, SGCCRI, Dr. Deena Dayalan sir, consultant medical oncologist at Apollo Specialty Hospital, Dr. Armugam sir, medical oncologist from Guru Hospital, Dr. Indu ma'am, group director and HOD, radiation oncology at Para Hospital. We welcome you all to today's session. Sir, over to you, please.
Yeah, so thank you, and I want all my panelists to open up their cameras so that we can just dive down into the discussion. Roshni, pull up my slides.
Yes, sir.
So this session was initially planned by Dr. Akhil, but then at the last moment, we medical oncologists get busy with so many more meetings. And I had to pitch in, and obviously I'm always happy to part of such a fantastic academic feast. So to all my panelists, so let's start very simple. So our topic of panel discussion is going to be, it's going to be the management of hormone receptor positive MBC. So, Dr. Nitya, how about your experience in your center? What's the average presentation of cases with hormone receptive MBC, and which is the subgroup? Whether you see more of PS 0, 1, 2, 3, 4, 4.5. So, let's start with that. Pure, simple, basic, so that students after these slides, they should be able to know what they have to answer.
Thank you, sir. I think it is important to know this, answer this particular question. And we all know that hormone receptor positive tumors are extremely slow growing for most part, except for those with a very high Ki67. So there are people who tend to present with a later stage in disease.
Yeah.
And I would add a little bit of site of metastasis for a basic oncology degree. I think we need to know that HR positive breast cancer, which is HER2 negative, the site of metastasis is mostly musculoskeletal, mostly skeletal, and sometimes other sites also. And most of these patients present in a very stable state. They're not in visceral crisis. The visceral metastasis is extremely low. Good performance status, small tumor, but a lot of metastasis happen. So I wouldn't be able to tell the exact percentages, but about 30% of our ER positive patients present with metastatic disease.
Okay. Dr. Rakesh.
Yes, please. Good evening.
So this answer is like in front. The question is like in front of you. Factors affecting treatment decision in frontline setting. So if I have to ask this question to one of my DNB students, so what they generally do, they just go blank. They are like, we can't answer. So what do they need to remember whenever we want to know something from them in hormone receptive MBCs management?
Yeah, so you're asking me what are the factors we need to keep in mind when we start a treatment?
Absolutely.
Yeah. So first of all, we need to first find out whether this is an upfront metastatic breast cancer treatment naive or the patient was earlier a EBC, early breast cancer, and has now come back with the disease. Number two would be whether the patient is premenopausal or postmenopausal or perimenopausal. Number three would be what kind of treatment the patient received before we take up this patient for any kind of treatment. So, and of course, these are some of the patient-related factors. We also have to see the performance status of the patient and various comorbid conditions and the contraindications to certain drugs. If we talk about disease-related factors, that would be whether the patient is strongly ER/PR positive, HER2 negative, or the patient is weak ER/PR positive or just ER negative PR positive. The KI value, whether the patient has visceral crisis versus aggressive visceral disease or just visceral disease. And in case the patient has been exposed to endocrine therapy in the past, whether the patient was endocrine sensitive or there was some amount of resistance. So these
So
are some
let's say
important.
if the patient is having, ER positivity of 1 to 3 by 8, yani ki, if it is less than 3 by 8, one scenario, and the another scenario is ER negative and PR, 6 by 8.
Right. Yeah.
And
So
HER2 negative, obviously, we are talking about in hormone positive.
right. Yeah. So it's for the residents. What we do in our clinical practice and in my center, we do the all red score, which
Yeah.
looks at the percentage of staining and also the intensity. So anything 3 by 8 or above, we consider that as hormone positive. 2 by 8 or less than that, we consider that negative. And about the second option, if it's ER 6 by 8 and ER 6 by 8 and
ER is negative and PR is 6 by 8. Yeah.
yeah, so usually that does not happen very often, but nowadays we are getting a lot of PR positivity, ER negativity. So we will give the benefit of hormone therapy to these patients, but I will communicate with the patient family members that you
Absolutely.
may not be able to get so much of benefit as you desire for a ER positive patient.
Fair enough. So, Dr. Indu, because it's going to be majority of a medical oncologist discussion, so I wanted to know where is the role of radiation oncologist when patients in metastatic breast cancer with the hormone positive status presents to us? Minded, it is not triple negative, it is not HER2 neu 3 plus. Any specific condition where you feel the need of radiation oncology is there?
Definitely. Radiation oncologist role will never go away even in a hormone positive metastatic breast cancer, because as already pointed out that these patients usually have musculoskeletal metastasis, and these patients because hormone treatment will the effect of hormone treatment will take some time to show. But if the patient is presented with lytic bone lesions, the patient is symptomatic, it's in the weight bearing bones, lumbar vertebrae, or all those sites, then definitely radiation has to be given. And one point that all of us missed out was we also have to see whether it is an oligometastatic setting or a polymetastatic setting. What are the sites of mets? Is it only bone metastasis? What is the volume of disease? What is the size of metastasis? All these factors also have to be taken into account, because nowadays the role of and similarly, like for bony mets, definitely we will consider radiation. And some role is also emerging for the role of SBRTs to the in a oligometastatic SBRT to the all metastatic sites. So, and if a patient is upfront oligometastatic with a very low volume disease, then we have evidence to give radiation to to all metastatic sites, or definitely also symptomatic bone mets. So radiation if any patient presents with a metastatic setting, ERPR positive, bony metastasis, radiation oncologist has to be taken into consideration, and it has to be discussed in a multidisciplinary tumor board regarding the role of radiation upfront. Because so many times I have seen that patients present with a bony metastasis, and they are diagnosed with a bony met, and after complete workup, when it's found out that patient has metastatic disease, then radiation is not given and patient keeps on staying in pain for a longer time.
Absolutely.
So what is the presenting symptom? Is it affecting the quality of life of a patient? These are all are very important parameters whenever you're deciding the treatment of any metastatic patient with ERPR positive status.
So can I have my next slide? Also, now I'll be shifting to Dr. Arumugam. Obviously, this is for the first time I'm meeting all of you, and it will take some time for me to catch your brain waves. So, Dr. Arumugam, are you here?
Sir has just left because of the connectivity issues. Sir is
Okay.
trying to join.
No problem. Dr. Deen Dayalan, I can see you. Okay, so very recently, I'm just pausing the discussion of hormone positive. So I had a patient of triple negative breast cancer with a T3N1 kind of a scenario, and she was having 3 bony mets, lytic lesions. And obviously, because when Dr. Indu started the discussion of oligometastatic, I just thought, let me just put it across the board. So some oncologists said, start with the chemo and keep the intent completely palliative. And we being in the world of oligometastatic, I said, you can go for chemo and immuno, and we will reanalyze once you have the next assessment due. So they took 3, 4 more opinions. Obviously, there was a debate. So I said, boss, if it is oligometastatic, our intent is going to be curative, and let us start you on this chemo and immuno. And they got the CPS done. CPS was hardly 1. Now the interesting story happens that once I have given her, 4 cycles of EC with Keytruda, I did the PET. Then what happened? Primary got shrink, lymph nodes went away, and I was able to see sclerosis in so many other bones. But mind it, all the lytic lesions were nowhere to be seen. It's all the sclerosis. Now from 3 lesions, I am seeing 10, 20 maybe lesions, and all are showing only the signs of sclerosis. So do we tag it as a progressive disease? Do we take it as the patient's pets, initial pets can missed those lytic lesions which were very minuscule, and we started with the therapy and they healed the lesion? Or do we change the entirely the treatment protocol? What's your take?
Actually, I have a similar experience of this kind of scenario, sir.
Yeah.
Thing is, first, this patient had somewhat weird clinical behavior. Though it is triple negative, we got bone metastasis. So, in my clinical practice, if it is possible, I tend to do a biopsy from the bone lesion, and I will do a IHC there, because we know that what we are taking as a core needle biopsy, it may miss some clone. What we are seeing is a one clone, and there may be some other clone is there. And since it's a tumor is a heterogeneous one, and so I would tend to do a biopsy from the bone lesion. I will check the IHC for the upfront itself.
Right.
And second thing, when the tumor responds, it will start to clear out actually. And I had a similar experience to a case osteosarcoma with lung metastasis. The initial lung metastasis, it is a few metastasis only. We started neoadjuvant chemotherapy. Since I can assess the local response, the lower end of femur, the tumor, the swelling completely gone off actually. When we did the PET CT, the local complete response was there, and lung multiple new calcified lesions are there.
Yeah.
Actually, when I went through the literature, I got some interesting facts that the lesions, when they respond, they will heal by this calcification.
Yeah.
Okay, so the lung lesion also responded, but it becomes calcified. But I can see more lesions compared to the upfront.
Yeah.
That for that I couldn't get any answer.
Yeah.
So in this scenario, I can say the patient had multiple bone metastases upfront and responded well, so turned to be a sclerotic lesion in the responses.
So do I still keep it as a oligometastatic curative intent, or I completely tell the family now it's not oligometastatic, it's a palliative setting. वो तो हम बच गए, हमने surgery नहीं कराया.
Dr. Aditya, what about, can we see the alkaline phosphatase levels? I mean, I'm just giving a thought.
Yeah.
If suppose initially alkaline phosphatase level was high, liver functions were okay, and only alkaline phosphatase was high, and now it is coming down, and now again it starts rising. Maybe that could be a scenario. And I don't know what would be the role of a bone scan in such a situation, but because
You have
normally we don't do it.
Answering that, you really don't require a bone scan.
And normally we don't do. Yeah. I'm just thinking of a scenario where or an MRI might also help in such situation.
So family asked me point blank question that do we address the primary now or not?
I think we should not. If there is a confusion, we should not.
So the problem is that patient is fantastic. She is doing well. Her primary has like reduced by 50% within the 4 cycles of epirubicin and cyclophosphamide and Keytruda along with denosumab. And now I've started her on, Pacli Carbo, the standard of care for triple negative. The only point here which one can challenge me that if this is now a metastatic disease, why are you still continuing Keytruda? Because the PDL1 score is, I think it was hardly 1%. So technically, I don't have an approval. So it becomes an off-label indication to add Keytruda. So I had to tell that family, I had to, jiggle my, all the thought was I had to document everything that initially the thought was this. Now the scenario is like this. So there are no rules in oncology. The more patients we are seeing, the more weird stuff is happening. And the
Dr.
question.
Aditya, I mean, I'm just thinking as I'm talking, like when you see there is pseudo progression on immunotherapy in other sites in lung. So has it been seen? I have no experience. That's why I'm asking this question. Do you ever see pseudo progression with immunotherapy in breast also?
Ma'am, with immunotherapy, you can see anything in the whole world. I have seen death with immunotherapy. I have seen acute myocarditis with immunotherapy. I have seen myositis. I have seen vitiligo, and I have seen
Those are documented
microprogression,
side effects.
pseudo
But
progression.
I'm saying,
Everything is possible.
so we should in such a situation we should see about the RECIST criteria of immunotherapy on PET. I think that
It just says, it's IUPD with the new lesion if it is there. But the problem is to tag it as sclerosis as the new lesion. We don't have any guidelines for that. Even that falls outside the purview of the races. Whether I take the eye races criteria or plain races criteria, sclerosis in the bone is not a criteria unless it's a prostate cancer or maybe a lymphoma. In breast cancer, Dr. Nitya, what's your take? Do you think sclerosis is PD or a lytic lesion is a PD?
It is very difficult to answer in breast as well as prostate. So I think for this particular case that you mentioned, it is very difficult to answer whether these lesions came initially, whether they are pseudo progression, because in the area of immunotherapy, it's very difficult to estimate the response. Even a partial response is very difficult to say because of a high
Primary from
chance of
5
pseudo progression.
centimeters has gone down to 3 centimeters now. Her node has gone vanished.
So I think it was probably an undetected skeletal metastasis at that point in time. I perfectly agree with Dr. Indu. Alkaline phosphatase has a very important role in diagnosing and assessing the level or extent of skeletal mass. It's a very sensitive marker, especially for patients with these lytic sclerotic mixed lesions. We've seen that as a very sensitive marker, and we are actually having a study that in patients with breast and prostate cancer. I will be able to consider alkaline phosphatase as very significant now. Phosphatase is going to be very useful to assess response. Probably the earliest forms of response assessment methods, even before we have the modern PET scans.
Right. So obviously, coming back to our topic, it is hormone positive. And at what level of hormone positive would you consider endocrine therapy? I think we had the discussion initially. We can move to the next slide. So in the setting of visceral crisis, is chemotherapy preferred, or chemotherapy is the treatment of choice? That's the question. And we have Dr. Rakesh here. So Dr. Rakesh, very simple question. I'll tell you my thought that
Yeah.
for me, I don't consider visceral crisis visceral crisis. I have been very happy with the simple dose of CDK4/6 inhibitor, and at least I have given it to 10 or 15 of my patients. Everybody has done well. So am I wrong, or am my eyes are seeing wrong, or the data needs to be tweaked?
No, you're not wrong, because if you look at the right choice study on ribociclib, they had selected a specific group of patients which were very aggressive visceral disease, almost going towards crisis, that is impending crisis. But to be honest, organ failure was not documented at that point of time. So you might have a heavy tumor burden, you might have patients having lots of symptoms, but none of the organs are showing evidence of failure. You don't have lymphangitis carcinomatosis in the lungs, your LFT function is still okay. I think you can give the combination of CDK4/6 inhibitor with a hormonal agent. That's what the right choice said.
So what's left now is to find those patients where our treatment of CDK4/6 should not be given. Is there any which subgroup you will be happy to start with on chemotherapy?
Yeah, so if you have a patient who has almost extensive liver metastasis, and the patient is started having constitutional symptoms of advanced disease, maybe those are the cases I will start chemotherapy. I'm yet to confirm the presence of a retinoblastoma gene mutation being done earlier on to predict whether the patients will respond to CDK4/6 or not. But those are the patients I would.
Right. So next slide. So visceral crisis, so to all the residents that you have to know this definition by heart, it's the severe organ dysfunction as assessed by the signs, symptoms, lab test, and rapid PD of the disease. Visceral crisis is not mere just if it is there on the PET scan and liver is studied, but there is no sign and symptom, there is no lab abnormality, you can't tag it as a visceral crisis. You need to have an organ in compromise report to tag it as a visceral crisis. And then obviously the right choice trial, I think this was published, and you have the answer of ribociclib versus the chemo. So next slide. And you can see the benefit is towards the doubling of the PFS. It is 24 to 12 months with a significant P value. So, Dr. Deen Dayalan, for our residents, how can they best tell us about hazard ratio? Because most of the times when we ask them to explain a simple hazard ratio, the statistical question, what should they tell the examiner, and how should they interpret the 95% level of confidence interval whenever we are asking any question or when they are writing an answer into the answer sheets?
Hazard ratio, generally, it should be less than 1 to have the statistically significant benefit. So to be simplified, it should be less than 1, and 95% confidence interval should not cross the 1. That is also puts more value to the hazard ratio. So it is the simplified version, and they can use these things.
So obviously, if any student needs to know that if this hazard ratio is there in front of you, first of all, it is showing you a benefit of 46% of the interventional arm versus the placebo arm. And then again, that is relevant in terms of the progression of the disease, in terms of the death. This combination is 46% less likely to cause that particular event, and it has a significant p-value. So whenever we ask you the definition of hazard ratio, be sure about which category it's being used. If it is in PFS, your endpoints become different. If it is asked in OS, your endpoint becomes overall survival alone, and along with obviously death is being there. So next slide. So in the absence of visceral crisis, I think there is a no-brainer over here. And Dr. Rakesh, so which is your favorite molecule? Let me start as per that. And obviously, this is not a commercial angle to here.
Right.
One answer, the best molecule, CDK4/6, which all students should able to remember as per the given literature. Which one do you recommend?
So if it's a premenopausal woman, it is going to be ribociclib. It has OS data, which is highly significant. If it's a postmenopausal woman, first line, I will go with abemaciclib upfront if the patient has bone compromise. Bone compromise in the sense the marrow compromise, because abemaciclib does not hit the marrow much and it is given on a daily basis. If the patient doesn't have any contraindications to any other this thing, then I'll probably go for ribociclib or palbociclib. And one more thing, if the patient has upfront brain metastasis, even if the patient is asymptomatic, abemaciclib scores over the rest too. And if the patient has extensive liver mets, then also abemaciclib scores over the rest too, because the separation of the two cups happens very early in liver disease when you give abemaciclib, and it also stays wide apart for a long period.
Yeah, and out of all the three, you have ribociclib, which is showing a significant OS benefit, and the rest of the two have been lacking behind to show a OS benefit. Even though when we discuss their numbers in terms of PFS, hardly 1 or 2 month differences there in the efficacy. But then again,
Right, in the premenopausal, I'll go for ribociclib, yes.
so next slide. So now, because the confusion is going to start, because now we are using more and more of CDK4/6 inhibitors in the adjuvant settings as well. So that can create some type of complication in managing such patients. So Dr. Deen Dayalan, if you have a patient operated on hormone therapy, lands up with the ET resistance, let's say it becomes refractory and the disease comes back while the patient is on Natalie. So what should we do then? How to proceed in such scenarios?
Our guidelines all applies only to that prior to the adjuvant CDK era, actually. What we are classifying as primary endocrine resistant, secondary endocrine resistant, that's all happened before the adjuvant CDK era. According to that, anything between the 2 years of adjuvant till 1 year completion of adjuvant, it's a secondary resistance. We can still consider some endocrine options, but when we give the CDK4/6 inhibitors, with that there is progression happens. I would assess the clinical behavior actually, and how rapidly it happened, and what is the tumor burden, what's the symptomatology. With that, I will categorize whether they are endocrine sensitive to plan for next line after doing the ESR1 mutation, PIK3CA, AKT, PTEN path analysis. I will choose either hormone, another hormone option, or chemotherapy.
So, where is the point to do NGS in such kind of patients, or do we do single or two gene or a hotspot panel? Any thoughts on that?
Patient who has progressed on adjuvant or who has progressed on prior endocrine therapy, there I would strongly to suggest to go for NGS, preferably a broad panel, or at least ESR1, PIK3CA, AKT, PTEN. This path should be covered.
Absolutely. So, can I have the next slide? So you have the snapshot of all the trials, Dr. Roy, and I think I'll just straight away go to the next slide. Next slide. So all these were phase 3 trial, and next slide. Yeah. And some of them, like Abima, obviously we already had a discussion. If you have a brain mets, or so I think these two palbociclib and abemaciclib.
Ribociclib.
Yeah, ribociclib. So next slide. I want to show you completely. So this was the earlier, presentation, and I want to open up the newer NCCN one. So give me a second. It might take a second. In your practice, have you ever tried this combination of inavolisib along with the AIs?
No, in fact, is this question directed towards me?
Yes, sir.
Yeah. So I haven't. I have used alpelisib in combination with fulvestrant. I do not have an exposure to LSS strength, so these are the molecules I've not used. No.
Right. And how oftenly are you able to pick up those ESR1 mutation or RB1 mutation that we are always worried about? Or is it a routine practice for you before starting the CDK4/6? Do we need to
No.
do that? And if a patient comes to you, say that finances are not an issue, would you
Yeah,
like?
well, no, we initially would not do this test. We would probably do maximum one test. That would be the PIK3 mutation because you have a
Yeah.
we have Biblic study to demonstrate that. But otherwise, ESR mutation, we test only if the patient has progressed very rapidly on an EI.
Yeah. So, can I share my screen now? Roshni, give me the authority to share the screen.
Yes, sir, you may share now.
Yeah. So what I want to show that we are now going into the era. So I think it's visible to everybody. So there we have this, and I want to share straight away to this. So now more and more FDA, approvals are being given to the exact combination like inavolisib, palbase, and fulvestrant, then elpelisib and fulvestrant, capivasertib with fulvestrant. And looking at these mutations, PIK3 or AKT1 or PTEN mutations, Dr. Deen Dayalan, how have you ever had an experience with using elpelisib or capivasertib?
I have used alpelisib, sir.
Yeah. And how comfortable are you in choosing such kind of drugs? I mean, are they doctor
A
friendly?
nightmare of dealing alpelisib adverse events. For my patient, beyond hyperglycemia, she had a severe anorexia. When
Yeah.
the tumor progressed after 10 months, patient was very happy
Yeah.
because I am going to stop the drug.
Right.
That's what she experienced. She had response at 6 months and she had progression at 12-month PET CT. Finally, we switched to another.
Right. So let me go one by one. For students, patients on ribociclib, what all do they need to know before starting, and what do they need to know after starting in the sense of adverse events? And they should be able to answer it. Dr. Deen Dayalan, you can take it. It's like kindergarten. The side
Yeah.
effect profile of ribociclib, what all needs to be there in our brain before starting ribociclib?
Yeah, important, most common adverse event is bone marrow toxicity. Generally, it will be a uncomplicated neutropenia only. So in the baseline, we tend to do the CBC, liver parameters, since the patient has chances to develop transamenities over the time, and baseline ECG that matters. And this patient may develop QTC prolongation. And generally, this ECGs has to be repeated every 15 days at least 2 to 3 times. If the QTC is okay, then we don't need to repeat ECGs thereafter. And every cycle we have to do the blood counts and liver parameters. As I told, the most common adverse event is an uncomplicated neutropenia. If there is a neutropenia, we can hold the drug for 1 week. Generally, it will come back.
Absolutely, and absolutely,
Febrile
you don't need to
neutropenia.
give filgrastim. That is very essential. That
Yeah.
it's a reflex that our students, they see, we have trained them. ANC less than 1500, ANC less than 1000. You write this, but this is the only subgroup where you technically don't require to do anything. And another point is in the terms of calculating the Framingham scoring QTC interval before starting ribociclib. It is very essential. And I have seen few colleagues, starting it without doing an ECG, ribociclib. It's medical legally wrong. And I have been able to pick up 3 patients where QTC by Framingham scoring was more than 500 milliseconds, and they were getting ribociclib. So I know we are bold sometimes, but I didn't know that we are this bold. Okay. So, Dr. Roy, what about your thoughts on abemaciclib or palbociclib, the drug-specific side effects that we need to know before starting this or after starting the medication?
Yeah, so the main difference between edema and palbo would be the bone sparing effect of edema cyclic. So, but it does cause a significant amount of GI toxicity, maybe diarrhea, maybe a bit of dyspepsia. Though the ones which have been reported amongst the Western counterpart is higher in number. I think the Indian patients have slightly better tolerance. This is my take, of course. I practice in the eastern part of India. They have a lesser GI toxicity compared to the Western counterpart. And regarding palbociclib, Dr. Dindal mentioned, I think bone marrow suppression is very important. You'll have to understand and wait as to when you need to restart. And the most important message from these drugs is even if you reduce the dose, the therapeutic efficacy is not compromised. So even if the patient is responding to palbociclib, even a 75 milligram works. And abemaciclib is probably the only one CDK4/6 inhibitor which you can use as monotherapy. So there are certain differences between these drugs, so they belong to one single class of CDK4/6 inhibitor.
Right. And also, Dr. Roy, I have like
Yeah.
few patients who came to me in like moribund state, a PS of 4.5, where they were literally about to expire.
Yeah.
And I did the workup and found that the tumor is having a hormone receptor positive and it's an MBC. So there I had to start with, Palbase because that's a very simple drug dosing. It's once a day. And secondly, I wanted to go ahead and give a fulvestrant rather than AI. The reason for that was that I wanted her hormones level to plummet down as fast as possible.
Yeah.
3 months down the lane, those particular subgroup of the patients, all three of them from stretcher, they started to coming to me in OPD in via wheelchair, and now they are walking. Now, question is, shall I still continue fulvestrant with AI or I switch it to AI with the CDK4/6? Mind it, they have responded beautifully, and at that particular time, I thought, let us just give the benefit of fulvestrant.
Yeah, so there was a very interesting study called the Parsifal study. Because fulvestrant is a estrogen receptor blocker, so they decided to see whether upfront fulvestrant and CDK4/6 inhibitor is superior to AI plus CDK4/6 inhibitor. The Parsifal study was a negative study. However, you have done a right thing because the tumor bulk was huge and the patient's PS actually deteriorated because of the amount of tumor burden. A drug which can act multiple ways, fulvestrant is not a bad choice, but then is responding, I may not actually change the drug because now we have data from the maintain study that even if the patient progresses, you can still continue the CDK4 and just change the endocrine backbone.
Yeah. So yeah, I think I'll stop sharing now. We move on to my slide deck and I'll just wrap it up another 5 minutes or so. So Roshni, pull up my slides. So you can just see fantastic hazards of all the CDK4/6 with the AI and even with fulvestrant. So this we all know, nothing new over here. Next slide. And minded to all the students, we are not interested in knowing the major data set. We are just interested whenever there is Viva or even in your theory papers, we just want to know, do you know when to use which drug? It's as simple as that. You should remember the name of the trial because these are landmark trials, and any trial which is a landmark trial which has incorporated these practice changing guidelines, I think one should remember the name of it. And if at all, at least if you know the PFS, fantastic. So only four things: the trial name, author name, if you get, it's going to be a gold mark for you, but we don't expect an author name. If you get the experimental arm and the placebo arm, PFS data, OS data, and side effect, we are very happy. We don't want to know more than that. The rest of the things you can still learn, but initial and starting point of all the CDK4/6, you need to know how one drug is better over another, in which patient you should give which drug, and which side effects to all we need to look out for. Next slide. Next slide. And this was the OS of Mona Lisa, and this is the only drug that has shown OS for Mona Lisa. Next slide. Next slide. So role of ADCs. So anybody can take, Dr. Roy?
Yeah, so now this is the new kid in the block. I mean, this drug isn't new. We have used trastuzumab deruxtecan long time back, but now you have data from two different trials, the Destiny 04 and the Destiny 06. The The main difference between these two trials is the Destiny 04 never included the ultra-low population, HER2 positive, and the Destiny 04 patients had been previously exposed to chemo in a metastatic setting, which the Destiny 06 data patients did not actually, trial patients did not actually get. So this is by and large the two major difference. So if a patient progresses on a CDK4/6 inhibitor and a hormonal therapy, at least 2 lines, then the patient will look for the HER2 status. So if the HER2 status is IHC 0, yet more than 10% of the cells take up membrane staining, even if it is faint, we categorize these patients as HER2 ultra low, and the remaining two would be 1 plus and 2 plus ish negative. These are HER2 low. So once the patient has progressed on first line hormonal agent and CDK4/6 inhibitor, you can give this drug to those set of patients. And in case the patients progress, you still have other drugs in the pipeline. As far as I am concerned, I am more inclined in using the Destiny 04 study data. I probably would be avoiding this drug in ultra low population. I'd be inclined to use it in HER2 low metastatic breast cancer or HR positive.
Right. So, Dr. Deen Dayalan, 5 treatment lines need to be decided now. First one, we already know it is CDK4/6. Patient progressing on that, I think we all need to do an NGS to make sure you don't have any resistant pathway mutation. And if it all is there, then you select the mutation-based treatment. And if it is not, then we change the AI to a fulvestrant,
Yes, sir.
correct?
Fulvestrant, and we have a companion like everolimus mTOR inhibitors.
Yeah.
So either fulvestrant or with some mTOR inhibitors.
What about the third line?
Again, if I didn't use mTOR inhibitors, I can use mTOR inhibitor with tamoxifen if provided they had a good PFS with the second line and still endocrine sensitive disease. I will go for one more line with the endocrine option like tamoxifen with mTOR inhibitors. And
Obviously, this being an academic discussion, cost is not an issue. Will you still retain that answer, or would you like to give a different answer in terms of secukinumab?
if endocrine sensitive disease, long PFS with a prior endocrine option, I would stick on to the endocrine before exhausting all endocrine options.
Okay. So then the third option is still an AI or an endocrine option if the patient is still responding. Then the fourth line comes to you. That becomes the option. HER2 is low. It's like 0. There is no expression. Then I think we'll be comfortable in using with secukinumab. And you have seen the recent data published in ASCO of secukinumab. Has anybody gone through that? Dr. Roy, the recent data of secukinumab in the second line, or I think in the first line, it got just published in ASCO 2025.
So I think this was the Tropion study. I don't exactly remember the name of the study.
Yeah.
Yes, I think they have shown very good results with sacituzumab. Yes.
So I think this drug is moving up the ladder like the TDXD molecule you see in DB09 in a different setting. It's like moving up like anything. It will definitely change our neoadjuvant intent of the TCHP as well. This is where the drugs of ADCs are going. So next slide. And obviously, no discussion is complete without side effect profile. So TDXD side effect profile was discussed in the previous panel, so I will not be going into the details of the side effect profile, but we should know the majority, the ILD, the cardiac toxicity, and fatigue. And to be honest, TDXD does produce side effects like hair fall, nausea, and fatigue. Your nail bed changes. You tell the patient that you are not giving them chemotherapy, but technically you are still giving them chemotherapy, and they will come back to you and they will complain you that you dog, you didn't tell me about the hair fall. So you missed it because you thought it's a mab. So that kind of things can happen. But then again, in real world practice, the side effect profile of ADCs are going to be as per the chemo as well. But this is the only way where we are giving highly emetogenic preventive medicines, even for Enhertu. And with the 5.4 mg per kg, the textbook dose of Enhertu, I think everybody is vomiting. If I'm not wrong, does anybody has any patient who tolerates 5.4 mg? Dr. Roy?
Yeah, so now they have recommended that you need to use NEPA for nausea vomiting, which is induced by antibody drug conjugates. And in fact, we have seen in couple of patients that that continues almost 10 days to 14 days. That's a pretty long time, nausea vomiting, in spite of giving NEPA. So this is one aspect we never told the patient, and patients are heavily pretreated. Some of them have major liver dysfunction. So you have to consider this before you start this drug. And to be honest, if you look at the vial strength, 5.4 milligram is such an arbitrary dose that you may not get a full number. So 230 means whether you give 200 or you buy 300, remove the 70 and give 230. Cost becomes a very big factor in the long run. So we have to be very clever, very prudent. We have to choose the appropriate dose for the drug. And we have to tell them that though this is targeted chemotherapy, you need to know that you might have certain serious toxicities, especially the ILD.
Next slide. So for osteoporosis, I think you can just take it in a minute, Dr. Deen Dayalan. You can just wrap it up then. AI-based toxicity in terms of AIMS, which is the musculoskeletal side effects, the vaginal side effects, the and the osteoporosis. So in three categories, you can just give a brief to the students what needs to be on alert and what.
Before starting aromatase inhibitors, we have to do a baseline DEXA scan to know their mineralization status. And those who are in extreme age with osteoporosis, even we can consider tamoxifen over AA in order to prevent the skeletal related event. That should be in our mind. Generally, we tend to know that AA is better drug than tamoxifen, but in that scenario, we can prefer the tamoxifen than AA. And the frequency of bisphosphonates will be decided. It depends upon the T score. So that should be in our mind. And other possible adverse events with the AA, especially letrozole, there will be myalgia, polyarthralgia. This is very common with letrozole, little less common with anastrozole. There is some difference. So those who are a bit old, we can prefer anastrozole over letrozole. And the periodic lipid profile. Hypercholesterolemia is one of adverse even with letrozole. We often forget that doing lipid profile. We can do lipid profile periodically to pick up that, and we have to add according to the values. And these are the things we have to look when we prescribe some aromatase inhibitors.
Absolutely. Next slide. So yeah, I think with this we are coming to the conclusion of today's a very short and a crisp CME, and obviously there has been no sponsorships over there. It was a completely academic based discussion, and I'm happy to say that all my panelists have been wonderful. And I think with this, back to organizers, and thank you, Dr. Roy and Deen Dayalan, for sticking with me till the last of this wonderful IAIO oncology updates. And obviously we'll be seeing you in more and more academic conferences, obviously in the other conferences as well, but I want more faces in the academic conferences. So, and thank you, Dr. Indu, as well, that at late night as well, you are here with us.
I learned a lot.
Thank you,
Thank
ma'am. So, Roshni, back to you.
Thank you, sir. Thank you so much for the informative sessions and many talks and interesting panel discussions. Now, I thank all of you for joining us for the sixth edition of Oncology Updates, focusing on breast cancer today. And we truly appreciate your time, insights, and active participation, which made today's session highly engaging and informative. This is just the beginning of an exciting series. Tomorrow, we continue with another critical focus area, prostate cancer, bringing together leading experts to share the latest advancements, evidence based practices, and clinical perspectives. We look forward to presence tomorrow as we continue this journey of learning and collaboration. Thank you.
Good
Until
night.
then, stay safe and have a wonderful evening. Thank you all. Thank you, sir. Thank you for having us today.
Anytime.